looking at continuing your education, always getting better at what you do. It shows in your empathy. It shows in your compassion. It's fantastic. My son is sort of pre-med, pre-dent, and I'm sort of seeing it from on the other end, John, and it's a very long and arduous road. So, however, a lot of you also, whether it's good to see you, whether we like to admit it in public or not, a lot of us are under a lot of pressure. You know, overheads in dentistry, I was looking into this, Brian, it's in sort of 60 to 70% in terms of overhead. Which one of you was the last time where you said, "Oh my God, I've got so much time. I'm not stretched at all. I'm doing just fine." Time is always difficult. Managing staff is always very, very difficult. And I think there was a study at UCSF last year showed that 38% of us dentists are going through some stage of what they call personal burnout because our plate is rather full. What makes me slightly upset is that even though you all signed up for the Hippocratic Oath of do no harm, the business companies that are supposed to be taking care of you did not sign up for that oath of do no harm. In fact, they know that you are busy. They know that you don't read the fine print. They know that you're distracted. And they pretty much plan for that. They see us as the low-hanging fruit, often charging us at their top rates. And that upsets me. The worst industry that I know that is like that is merchant services, credit card processing. It's unbelievable. Our Jennifer Shearer, who I'll introduce you to in a minute, has, you know, when she goes through credit card statements, the craziness of rates, the craziness of silly fees that you're being charged, high-risk fees, PCI compliance fees. It's a really terrible industry. That's part of the reason why I, along with 16 other clinicians, formed a company called UniFi. And the reason we formed this company is we wanted to form a company that didn't look at clinicians from the outside, but took care of clinicians from the inside. To us, you're not clients, you're colleagues. And we saw a gap in the market there because we felt that you know, we understand your reality. And more specifically in terms of what we do, if you look, George, in your private practice, you need to have credit card processing, right? That's one company. Patient financing, a second company, second relationship. Payroll, third company, third relationship. HR, fourth company. Ability to get loans to buy some of the wonderful things that you're going to need for digital dentistry, fifth relationship, fifth company. What we did at UniFi is actually really pretty simple. One, we did 3 years of research to find best-in-class companies in the domains that I just described. 3 years. Then we negotiated clinician-first rates. Unbelievable rates that singular private practitioners cannot get. Dare I say the dirty D word, sort of DSO level rates. And then we consolidated it all together on one platform. That's not to say that you need to adopt all of these services. You can adopt as many of them as you like. But the purpose here was to do the hard work for you, to do the negotiating for you, and then put it in one place so that if you needed to take a look at it, you could. Now, the thing that's really important is our process. And that's what really makes us different. We take a look at where you are at with any of these services. We take an honest look and see, hey, where are you at? And if you're in a great place, we'll validate that and we'll celebrate it with you. There's no, bait and switch, we'll start with some silly rate or what have you. So you get what we call a diagnostic checkup. You may be in a great place,
Let's just validate that, and that's fine. But if you're not, we present your options to you in a very, very honest side-by-side way, so you'll know exactly where you are at. Now, then, what was the trouble? The trouble is you're busy to start off with. So we do all of the heavy lifting of the implementation for you. That's the accessibility part of what UniFi does. There's a part that's really near and dear to me is the allyship part of it. This community, being able to bring unbelievable speakers like Jhon Cranham so we can learn together, whether it's on the clinical front or the non-clinical front. A lot of our lectures, we'll send it to you, are on investments, leadership, management. Let's get better together. And lastly, we give 5% of our profits to 2 charities, UNICEF and Operation Smile. They're dear charities to me. Now, when someone like me stands up here and talks, your brain is, because I've been where you are, your brain is like, okay, whatever, he's da-da-da-da-da-da-da. The best thing to do is actually talk to folks who we are taking care of. And I'm just going to ask, who here is part of the UniFi family at the moment? Great. Seek one of these guys out and ask the questions that you don't want to ask me. Like, is it really true? If something isn't working out, do they force it on us, or are they honest about it? What was the implementation like? Did they take care of you? Did they sort things out and then leave, or did they stay with you? These are the these are the folks that'll give you the truth. So thank you for listening to all that. And now I had a PowerPoint, but I'm very scared of cables and audiovisuals, so I decided not to use it. Now let's what you guys are all here for is to hear Jhon Cranham, and I cannot tell you how excited I've been. I did a lecture in February, and the culprit was Dr. Gray to invite me to Chicago to do a lecture at the AARD. And it was, I nearly soiled my pants because I looked out at the audience and I saw Jhon Cranham sitting there, and I was like, oh my God, this better go well. He is a husband, a father, a dentist, a dental educator, and a best-selling author. He focuses on cosmetic aesthetic dentistry, implant dentistry, solving TMJ and facial pain problems, and solving complex problems. Now, you graduated annoyingly with honors from the Virginia Commonwealth University. So I was always at the bottom of the class, so I resent the top of the class, folks. And you were a clinical instructor there for a while, from 91 to 98. And it is absolutely true that during his 25 years as an educator, he has become one of the most sought-after speakers in dentistry, and we're so happy that he's here today, whether it's national or international lectures. He's published a book that many of you probably will know about. It's called The Complete Dentist Manual, and you co-authored that with Pete Dawson, who is a mentor of yours. What you guys might not know is that he is a best-selling author, and one of his books that is not so much about dentistry. In 2020, he published a book called The Cornell Effect, A Family's Journey Towards Happiness, Fulfillment, and Peace. And I look forward to hearing more about that. But he's going to talk to you this morning about the future of dentistry and digital dentistry, and please give him a really, really warm welcome, Dr. Jhon Cranham.
Thanks, Cruz. Well, thanks, Cruz. It's great to be here. And I've got about 3.5, almost 4 hours with you, and talking about probably my most favorite subject in dentistry, which is digitally driven restorative excellence. So one of the things that I think is really interesting about where we are right now is that some of the people that are most knowledgeable about digital, that really lean into it, tend to be the younger docs that may not be the most experienced docs. And while a lot of them are very, very good dentists, for those of us that have a few gray hairs know that the longer that we do this, the wiser we get and we start knowing our mistakes and how to do things. And I would say that a lot of the younger docs that are driven to technology may not know the concepts of aesthetics and occlusions as well as some of us that are a little bit older. Conversely, those of us that are a little bit older are scared to death of technology. And so we're in this kind of precarious place right now that it would be great if some of the people that really knew dentistry at the highest level would embrace these things. So Dr. Dawson, who is one of my great mentors, one of the things that amazed me about him was his ability, even till his, in his dying days in his late 80s, was always intrigued by these things. And he challenged me and Drew along the way to be looking and watching. And so I probably started paying attention to the digital space in about 2000. I was a fairly early adopter into CIRAC and E4D and some of these things. But honestly, when I was looking at E4D and CIRAC, what I wanted to be able to do with it was to plan. I didn't care as much about milling single units, although we did that, but I was frustrated that we couldn't take a FACEBO and we couldn't put it on a virtual articulator and really look at the occlusion like we were doing in the analog world. And so what I'm excited to show you today is that there really isn't anything that we used to do in the analog world that we can't do in the digital world now. And so it was probably about 2017 that Lee Culp, who's a lab tech that you'll hear about a little bit today, we have a company together now, training doctors how to do some of these things. But about 2017, he was working with the 3Shape lab software, not the Trios, but actually the lab software. And he called me and he said, I think I figured out some workarounds on how we can do trowel equilibrations and how we can do these things, and come look at it. And so that was about the time that I drove down there, and I think Drew and Ian Buckle in the UK were kind of already playing around with it. But that's when it all changed. And so we really haven't looked back. So it's now we're year 8 in a lot of this. And so what I want to do is just take you on a journey. I want to take you and show you a bunch of cases, things that we can do with implants and restorative dentistry. I want to review the principles of aesthetics and occlusion quickly, just so we're all on the same page of what we're seeing in these cases. We'll look at an implant case. We'll look at altering vertical dimension. We'll look at a lot of different things. So I was told from Peruse that this is a pretty high-level group, so I'm going to talk to you that way. If you've got a question, don't feel like you got to wait. This is a small enough group that we can chase as many rabbits as you would like to along the way. Okay? So the first thing is this is my path. He mentioned finished at VCU. It was the Medical College of Virginia back then in '88. Studied with Pete Dawson from '88 to '91, and then went through Pankey. Then I kind of got on my cosmetic dentistry kick and listened to Hornbrook and Nash and Rosenthal and Dickerson, all those guys. Spear and Coyce hadn't divorced yet, so I studied with them from '96 to '98. And then what got me speaking was, what I noticed was a lot of the people that were a little more functional, their dentistry didn't look so great. And a lot of the people that were doing really beautiful dentistry didn't know anything about occlusion. And so I created a program called the Cosmetic Occlusal Connection, blending the concepts, and that's really what got me going. Had a little thing called Cranham Dental Seminars. We were doing some lectures and hands-on at Bayview Dental Lab in Virginia Beach. That's when I met Drew. And then I joined the faculty at Dawson in '04, and I was the clinical director there from 2007 to 2020. So Pete died in 2019, and our other partner retired, and so it was just a good time for me to step away. And I really wanted to lean into the digital stuff. And that's what I've been doing. And part of this has been the Pankey Institute welcoming me back and doing some digital courses there. But I want to be clear that I got interested early, all right? So I got really intrigued by it and early in this process. So today, what I would like to do is, number one, review the key principles of aesthetics, occlusion, and biology for restorative success. Really want to make it clear about that because the principles are not changing, right? Joints are still joints, muscles are still muscles, teeth are still teeth. We got to honor, periodontal health, and we got to get caries out of teeth. All those things don't change. And so I think sometimes when you're learning digital workflows, sometimes the company that's selling you the scanner or the printer don't know the principles, and they're sometimes teaching you workflows that actually take you away from the principles. So I want to make sure you understand we're not doing digital just to do digital, right? We're doing digital to solve problems. We're hopefully doing it so we can be even more predictive, that we can be more efficient, and hopefully more profitable. If we can get predictability and efficiency going, profitability is usually going to be the byproduct in the long run. I want you to understand what is possible in digital dentistry today. And it may not be possible in your practice tomorrow because there is a learning curve with some of this stuff, but I do want you to understand what a lot of us are doing with these cases and how we're doing it. I want you to understand the available digital tools and how they will improve predictability, efficiency, and profitability in your workflows. And particularly, we're going to be talking about input devices like scanners and CBTTs and ModJaw and all these different things where we can gather data. We're going to talk about output devices like printers and mills. But what we have to remember, in order to get from a data collection device to an output device, there has to be data manipulation, which is software. And that's what we forget about. As dentists, if we're going to do this in-house, you got to have software. And a lot of the scanners and things will come up with kind of cheap software, but if you want to have virtual articulation and be able to, you've got to have some software. And we'll talk about the two players, which is 3Shape and Exocad, right? I want to outline a logical sequence of integration of hardware and software depending on your practice. And what I find where dentists get really frustrated is they'll go, I'm going digital, I'm going all in. I'm buying a scanner, a CBT, software, a mill, and a printer all at one time, and they frickin' die. It's like, that's impossible. So what is logical? Obviously, most of us are scanning. Do you get software next? Do you get a printer? Is it a mill? Depends on what you're doing and the style of practice. But the good news is this is a marathon, not a sprint, and you can start experiencing ROI a little at a time. And for me, it's been about a 4 or 5 year integration. And I bought a mill yesterday, so I'm finally getting to the point where we're milling. Before, it's just kind of all been printing. And again, provide a roadmap to learn how to make these digital tools routine in your restorative process. That's my goal. I want you to see, like, this makes sense to me. So nuts and bolts dentistry or more complex dentistry, how are we going to do that? So let's begin with the reality of where we are and just look at a case. Let's just start with a fairly complex situation and just from 10,000 feet look at how we're going to handle this patient's problems and situations. He's 53 years old. Brian, he's type 1 diabetic. It's controlled. He has thyroid disease, which controlled high blood pressure. Does have sleep apnea, and it's controlled with CPAP. Mild generalized gingivitis with some spot bleeding, some mild localized periodontitis. He was actually referred to a general dentist, to a periodontist, and the periodontist referred the patient to me. History of 4 bicuspid extraction, class 5 cervical lesions. The good news is joints are good. Normal range of motion, normal load test, no history of joint sounds. Does have some sore muscles to palpation, has some headaches. And the periodontist really thought this was going to be a great all-on-4 type case. So if I'd look at it, wants to improve a smile, is a pastor at his church, and is honest with me that he's concerned about cost, right? So we look at him, and he does have pretty significant wear and tear on his teeth. Does have a lot of what looks like bone, but I haven't probed or anything yet. But this is the face a lot of times of airway-driven wear where you don't see quite as much on the back, maybe some erosion from some GERD, but in the process of trying to open his airway, he just destroys his anterior teeth. And the more you destroy your anterior teeth, the flatter the guidance, the more you get on posterior teeth, the more the muscle activity goes up, and we'll hit some of these concepts a little bit. But yeah, I first look at it, and I'm thinking, I'm not sure why we have to take all these teeth out. I'm looking a little more closely, but let's just keep going through it. And the first thing we like to do when we're looking at patients is just look at their face, look at their profile. The stop bang analysis is a great screening tool for airway. And even with the stuff on his chin, he does look a little bit overclosed. His upper and lower jaw does look back a little bit. And he does score very high in the stop bang. And if you're in that 6 range from 5 to 8, you are high risk for OSA. And we already know that he has it because he had previous diagnosis and he's on CPAP. So that makes me feel great. I mean, we know it's a problem, but we know probably some of the bruxing and grinding related to the airway is under control. I talked to the physician who's treating him, and follow-ups say that his AHI is in the normal range when he wears it. Look at his probings. He's kind of 2s and 3s, and we look at his x-rays. Here again, this one's a little suspect. There's not a lot of tooth structure left on that lateral, but is anybody fired up to take all these teeth out? No. So here again, I'm kind of like, so right at this point, I'm looking at the x-rays, and he knows he was referred for all an X. And I said to him, I got to ask you a question. I said, do I have to take all your teeth out, or if there's something else that I could do to fulfill your goals, are you open to that? He goes, yeah, I'm totally open to that. He didn't want to do that. And often, if we don't take all the teeth out and do all an X, we often can phase treatment a little bit and show you how we can kind of do that. I mean, he's going to need a full mouth rehab eventually, but what if we could organize his occlusion with creative ways, maybe printing little toppers for his back teeth? I mean, there's ways to segment this, which is the direction we're going to go. But step one in any good treatment plan is good diagnosis, right? A lot of times there can be a lot of different plans, different ways to skin the cat, but there's often only one diagnosis. And so the airway is a big part of it. His occlusal interferences are a part of it. And we look at these photographs, and you can sort of imagine where you would like the lower incisors to be. You can imagine where you'd like the upper incisal plane to be. And that's really the process of what we're talking about. What we know for sure right now, looking at him, is his occlusion is not working, right? We've got to do something different. His aesthetics are not working. So taking photographs, taking scans, getting it into an environment where we can start designing and start thinking about where the teeth could be for great aesthetics, where they could be to have a good occlusion based on Dr. Dawson's philosophies, which we'll talk about, is going to be key. We like these 4 pictures to tell us about where we would like the incisal edge. You'll see them over and over, but this is lips in repose, or the rest, and we would like to see 1 to 3 millimeters at rest. In the E position, we would like to see the edge about half the distance between the upper and lower lip, so in that midpoint. So both of these are showing that we're probably a millimeter, millimeter and a half short. And how do we do that? Well, this is the photograph that we're going to base our length decision on when we start doing our diagnostic design, either analog or digital, right? Whether you're waxing or doing something in a virtual environment. The tip-down smile shows us where the incisal edge should be horizontally, and we'd like to see this edge following the intervermilion border. This is back. Why is it back? It's back because as teeth wear and you lose tooth structure on the lingual, the pressures of the lips bring the teeth back. So we start, it's why in end stage wear we often see a class 3 edge-to-edge type relationship. And again, profile smile, you can see that relationship. So visualizing maybe 1.5 millimeters, 2 millimeters of length, bringing it out maybe a mil or 2 in our design. Up top, he's got gobs of attached tissue. He's like a donor. On the bottom, not so much, right? So we probably are going to have to talk about potentially some grafting down here. That looks very, very thin. So when do we put that in the mix? And then just some of the cervical decay and things that we're going to have to deal with. We see some gingival irregularity because as teeth wear, they erupt. So the tissues of 8 and 9 are a little too incisal. And just the mirror shots looking at the posterior kind of destruction, which is a combination of erosion and some of the caries in the class 5 areas. So I was kind of looking at this tooth. 10 worried me a little bit, whether there was enough tooth structure there to grab onto. But then I also started to think about the fact that if we do some crown lengthening to level things, there's going to be a lot more tooth structure to grab onto. So maybe we can build up and do crown lengthening and get our ferrule effect that way. The things that you think about in the middle of the night when you've got cases like this haunting you. So we'll take our scans, and one of the things, depending on your scanner, there's some scanners, the iTero being one of them, that allows you to do a multi-bite. And so we'll show you how we do this, but we scan an MI just to get their natural bite, and then we'll use a leaf gauge to deprogram them and scan them in centric relation. And on a case like this, and I hope you see this, it's going to be very difficult to restore him without changing his vertical, right? Many times what we'll do is add a number of leaves to the leaf gauge and just look in there to see if visually the space what could be. Now I can still tweak that on the virtual articulator, but I like taking an open CR record with the leaf gauge. Leaf gauge goes in there. I added about 20 leaves. I'm looking at it on a leaf gauge. Each leaf is 1/10 of a millimeter, so that's about 2 millimeters of opening at the incisal edge. So you can play around with that. But the other thing that I want you to notice on a case like this is notice, let's see, do I have it? Yeah, here we go. Watch the video. Look at how class 3 his canine is in MI, but notice in centric relation, because he opens on an arc, notice how the canines come back into a more class 1 relationship. That's one of the real benefits of considering vertical. If you see somebody who's edge to edge and the class 3 canines are class 3, you change their vertical and all of a sudden things are lining up better. It gives us space to do things, and it often helps us put the canines in a good relationship. But that's a good, we see this over and over. So look at the canine class 3, watch it open in centric. Centric, you don't drop straight down, you open on that arc. And so this is how I'm looking at this case. About 2 millimeters open, I'm looking at where that canine is going to end up, that cuss tip landing on the mesial part of the cingulum of that upper canine, and I can start seeing how we can add things back without cutting more away. Like, we don't want to cut more away, right? He's already lost a lot of tooth structure. So we'll go through this in detail, but when we mount on a virtual instrument, this is inside 3 shapes. The first thing that happens when we open the software is there's a platform, and we basically line the maxillary incisal or the maxillary scan onto the platform, and you'll see the outlines of teeth, and you put the central incisal edges of the scan where the central incisor edges are on the platform. What this does is it puts the incisal edge 100 millimeters from the condyle on the virtual articulator. That's the Bonwell point. That is an average that's in bend dentistry for a very, very long time. And Drew found a study that basically shows that when we're using ear bows, which is also an average, that we're within about 10 millimeters of norm, either way we do it. The Pankey Institute has now gone to a DFA, dental facial analyzer, which is based on this exact same geometry. So what I want you to think about is the maxillary edge, or this maxillary scan goes on this platform. The mandible's going to come in wherever you scan it. There's no wax bite record. There's none of that. So once you scan it there, those georeference points are maintained. And we're only going to use the CR scan if we're working. So there's the articulator, incisal edges, 100 millimeters from that condyle. The mandibular cast is coming in the exact relationship where I scanned it at the VDO of where I scanned it, and this is the starting point. Okay? We have the same ability to change the condylar path, the same ability to change the Bennett. We can open and close, we can see interferences, we can do all that. And we'll see this all the way through today. Yes, sir?
How does it account for cant?
I'm going to show you that. It's a very, very good question. And I'll just answer it shortly and then I'll show you. But one of the powerful things about digital is we can stack data sets on top of one another. So we take a full face photograph of the patient's up like with the eyes level, and then we can attach the maxillary scan to that. So when we overlay the face on the articulator, we can see that, and I'll demonstrate that. He was pretty level, but right now just kind of assume that this looks nice and level. So when we do designs, we're not really waxing. We have about 100 different tooth shapes, molds that we can choose from. And in this case, I've done the design on the top from first buy to first buy. So I want you to visualize I'm thinking about doing crowns from first buy to first buy, but to phase treatment, these are what we call toppers, which are basically diagnostic design that will be printed to be able to just attach to the teeth. So I'll have a wax up of first buy to first buy, and what's back here will be removable. So that can just be bonded to the teeth. All right, so you can see we're starting to develop a good occlusion there and get our stops everywhere. Again, toppers on my molars, first buy to first buy. We're visualizing doing crowns. And on the bottom, because we're trying to phase things, I'm just going to do some direct resins on the back, kind of fill in the potholes. And I'm going to do resin restorations, canine to canine. Two reasons. One is he's got to do some grafting down here. He doesn't really want to do the grafting in the first round. So I'm trying to get his occlusion organized so we're at the new vertical, in-centric relation with good stops, good disclusion, good envelope of function, good crossover, all those principles of occlusion. And then when these 8 permanent crowns go in phase 2, we can decide what is next, whether that's grafting, whether it's doing some back teeth, and we'll get to that in a second. But being able to visualize not only the occlusal context, but be able to visualize guidance is going to be a big part of what we're doing. We can even see crossover, which is something I'll talk about a little bit later, where we go past the canines and go smoothly onto the incisal edges, skipping the lateral. That's what's key. And of course, protrusion, we want to go straight out, edge to edge. So let's just look at the case here. So what I'm thinking about in this first phase, you're going to see that we treatment plan biologically first, functionally second, and then we do the restorative stuff last. So basically 4 quadrants of scaling and root planing. Periodontist is going to do that. I'm going to do some class 5 resins. We're going to do buildups 5 through 12 at the time of the prep. And then the crown lengthening is going to be done on 7 through 10. We're going to be doing bonding first buy to first buy in the bottom. And this is kind of prep day, so we're going to be doing the bonding on the anteriors and the little potholes in the back. I'm prepping 5 through 12, bonding the toppers on 2, 3, 14, and 15. And then we're going to be putting the provisionals in. One of the things that I like to do in these cases where crown lengthenings need to be done is that I'll often do the just do the laser surgery right into the biologic wit, put my provisionals on, a printed provisional, and then the periodontist does the surgery after me. This is a way for us to just let me get this thought through. It's a way for me to really be able to see my incisal edge, see where the gingival margin is, and then all the periodontist is doing is reflecting and putting the bone 3 millimeters from my margin. And I'll show you that. All right, so then because he's healing from the crown lengthening, I have not done a final scan yet. of the crowns. So what I like about that is I have time. I can almost use the provisionals as an orthotic. I can equilibrate, make sure everything's comfortable and dialed in. And then when he's ready, we pretty much just take off the crowns 5 through 12, scan, make those, deliver a maxillary orthotic, and then he's kind of good until he's ready to do the next phase. That's what I'm thinking. So trying to turn this into an 8-unit case for him with a little bit of stuff. Yes, sir?
What kind of temperamental and joint assessment do you do so you know that you're ready to go to this part of treatment?
We'll go into that, but we do CBCTs and a full, Pankey Dawson style assessment. I mentioned it. He had normal range of motion. He had a normal load test. He had a clean CBCT. He had no history of joint sounds, Doppler. Pretty clean, okay? All right, so we're going to go ahead and print now the diagnostic, different case, but when we come into cases, we're going to have a provisional matrix. We're going to have prep reduction guide matrix. And again, visualize he's going to have some toppers in the back and matrices for us to be able to do the rest of the dentistry. So this is first phase. So we're kind of ending that first appointment. I've done some of the laser stuff here up top. The toppers are in the back. He's open now, so this isn't his occlusion. And then I did a pretty monolithic injection molding technique for my resins. What I like to do with my resins is keep them, polished and the contour fine, but when I deliver my crowns, I actually do a minor cutback and layer with a microfilm. And that allows me to choose a shade that's very much going to match the final crowns. And so you'll see that in a little bit. All right, so that's where he was. This is where we're starting. You can see that definitely have enough ferrule effect on that kind of beat up lateral number 10. And so now you can see the vertical we're at. So there's the toppers, there's the bonding, first spy to first spy. Good space for us to work. Now we're going to get into printing provisionals later. There is a workflow that Drew and I both like to utilize where if we give the lab the diagnostic design in advance, the day that we prep, we can send the scan to the lab and they can align our design over the preps, attach it to the margins and send it back to us in about 15 minutes. And then what we do, so we can print the provisional. So I'll keep that for later in the day, but we actually went through that with him on this. So here's his temps and now. Now, one of the things about my practice, and you'll kind of see it throughout the day, but I'm in a suburb of Virginia Beach in Chesapeake, which means I'm about 15 miles from the ocean front. And I kind of joke, but I kind of don't. But if you take a shade guide and lay it out, the closer you get to the beach, the whiter the teeth get. And the further we get out into the peanut country out west, it goes like A1, A2, A3. So he's a little further out west, and he was very happy, but he was like, dude, we got to tone these down a little bit. I don't really hear that too much, but he was one of the ones, they were a little too bright. Yes?
How do you make your prep reduction guide?
So with veneers, we'll show you. Crowns, it's a little bit different. But what we do with the diagnostic wax up, or diagnostic design, is we make a matrix just like a crown, but instead of cutting it like vertically, we cut it horizontally through the tooth. So if you imagine cutting it horizontal right through the center of 8, you can look at it from the side and see all 3 planes and the lingual contour. And so if you do that, it usually gets us pretty close. Does that make sense? Yeah. All right, so looking pretty good. And we'll fix all this a little bit later, as you'll see. But now he's just healing. He can go to the periodontist, get his crown lengthening done, and we'll just see him every couple of weeks. We're putting him back in centric, making sure his occlusion's stable, making sure he's comfortable, making sure he's guiding, making sure he's not rubbing on back teeth. It gives us a little bit of time. And you can see this is now the scan about 3 months later as we're getting ready to send it to the lab. We're also going to take a full series of pictures. And one of the things that we noticed with him is it's still kind of back. So we gave Lee the artistic ability to keep the length the same, but just give me a little more vertical. That's not going to hurt him. Shallowing him is never going to hurt anybody. Shallowing the guidance, if as long as it still discludes the back teeth, is going to be a positive thing. Rest looks good. Guidance is there. And then the scans. Okay, so the toppers are just hanging out back there, and we're now going to finish first spy to first spy. And when I put in my crowns, then I'll do the micro layering on the bottom. And so this is what we ended up with. This is monolithic zirconia that Lee uses almost a liquid, I can't remember what it's called, but it's a porcelain that he can add for some of the, for the characterization, which looks very, very good. And it's not like a glaze, so you don't have to worry about it coming off. There's E. And there it is with the bottom, with the micro layering on the bottom. So you notice with the resin how I stopped short a little bit. And our second phase, he's going to go through the grafting. And what I like about resin being down here is my periodontist can peel that as easily, cut that back, right? And try to get as much root coverage as we possibly can. Again, we'll talk about this in a second, but equal intensity contacts, guidance off the canines, guidance off the centrals is what we're going to have most of the time. And we want to have things nice and smooth for them. That's that crossover going past the canine, skipping over the central or the lateral and smoothly going onto it. Might even a little bit of a bump on the right side, but it's looking healthy. There's our post-op x-rays, pre-op to post-op. So as we look at a transformation like this, there's definitely a lot that goes on between here and here, right? That's the whole case. A lot of us think it all happens between the temps and the final restorations. But in a case like this, and this is what I think is one of the differences between general dentistry and restorative dentistry, or PROS, is in general dentistry, often the only thing that the temporary does is just protect the tooth until the crown comes back. And when we're doing 1 or 2 units, it works. I mean, the lab can determine it all. But in a case like this, where his aesthetics aren't working, his occlusion isn't working, we have to do a lot of design to get to this point where we can see if what we visualize is working. This is the planning phase, right? And this is the communication phase. We're always going to make some changes to the temps, whether it's tweaking the bite or the length, but once we scan that patient and doctor-approved provisional, the lab is pretty much going to copy that. That's how we communicate to them, through the provisional restoration. So this is what we're visualizing right now. He's actually about a year out, and he had the crown lengthening, the grafting for the insufficient attached tissue on the bottom there. And then in terms of the posterior, it's like, I don't know. Is he going to do one side? Is he going to do the uppers next? Is he going to do the lowers next? I don't know. But he gets to choose that, right? And to think about it is, after we've gone through phase 1 and phase 2, it's kind of a general dentistry case. CR at MI is the same. He's at his proper vertical. If he wants to do these one at a time, he could. He's not going to do that, but it's now set up for him as a pastor to do this over a period of years if he needs to. Essentially, about 15.5 hours I had into this case from the time of the planning. And if you're wanting to know, like the digital designs, we do all that. We have the software, we do it all in-house. My son does the mountings for us, and he'll get the teeth, as I'll show you, kind of in position. But a diagnostic design in my hands, in my practice, a case like this, is about 35 to 40 minutes, well worth my time. Whereas if I was doing this old school, with a waxer in my hand, which I used to do, it would be 2 NFL games on a Sunday. I'd sit there and wax and wax and wax. And I'm not using Matt Roberts or Lee Culp's anatomy. So let's go into the boring part of the lecture, which I'm going to try to go through quickly. But what fundamentals do we need to know to execute a case like this, right? And so I want to talk about that. And how do these principles help with everyday dentistry as well as big cases? So let's look at some aesthetic and functional goals. By the way, if you guys want the slides, I see somebody, if you want to take pictures, I'm fine with any of the picture you want to take. But if you want the slides, I'm happy to give a PDF to peruse and he can send it to you. So just let us know. All right, happy to share anything. So the first thing to remember is the most important skill set any dentist can learn is the ability to visualize precisely where they are going and develop efficient workflows to get them there regardless of the complexity of the case. I'm a believer that this generally does not happen in dental school with the bigger things. I mean, we get a good idea of biology and a little bit of occlusion, a little bit of aesthetics. But to really start understanding this, it just takes time, dedication, and commitment. And so, as I've touched on the 4 food groups of dentistry, we have to have good aesthetics. We have to have good understanding of occlusion. And again, I'm going to tell you my philosophical approach. I understand it's not the only one. That's fine. We can argue about that later. But let's just have a philosophy. Let's just have goals that we're trying to hit. Whether you believe Pete or Pankey or John Coyce or Spear or Dickerson, I don't care who it is. Just have philosophies that work for you. Much better than not having philosophies. We want to have some biologic health, like what that means to you in your practice. And then we have to have an assessment of tooth-by-tooth structural integrity. Like, when are we going to do a crown? When do we do a filling? When do we do an inlay? When do we do an onlay? When do we take the tooth out and put in an implant? When do we do a post and core? Those are, tooth-by-tooth decisions. But what I would say to you is where I think we make the mistake in planning is we often spend all our time down here first, trying to figure out what we're going to do to each tooth, and then try to figure out this. And I think it should be in reverse. Figure out where the teeth go first. Don't even think about what the restoration is. Where's the incisal ledge? Where's the gingival plane? Where's the vertical? Like, how are things going to line up? Then go tooth by tooth. And that often gets you there in a very, very good way. So Pankey, Spear, Coyce, Dawson, these are all the kind of things that exist because as dentists we need to know this if we're going to start doing more complex things. So traditional treatment goals, but contemporary tools. And so I'm going to, before the break, go through some of the goals. We'll talk about the digital tools. Stand up, have a little coffee, and then we're just going to go through a bunch of cases. So let's talk about what makes a smile beautiful. As we start looking at teeth fitting properly in the patient's face, central incisors are in that sort of 10 to 11.5 millimeter length, provided the incisal edge starts in the right place, and if the patient shows some tissue, making sure everything's level and in harmony with one another. And so it really starts with this incisal edge position. And as I told you, as we look at this incisal edge position, the key photographs that we're going to take to analyze that are the rest position, the E position, the tip down smile, the profile smile. You're going to see that over and over because we're going to analyze that. And that really tells us a lot about where the incisal edge should go. And then the smile line tells us where the lateral, cuspid, and premolar should be. Virginia has a really beautiful curve to her lip, which means the lateral is going to be shorter than the central, the canine's a little shorter than the lateral, the vi's a little shorter than the canine. If her lip was flatter, they would be more on the same plane. Beautiful smiles do not have space between the edges of the teeth and the lips. You see it, follow that, all right? So we've got to have some nice pictures of smiles and some of these dynamic movements. I see doctors taking videos now of smiling and talking. And I don't like that as much because I don't know where to stop it. Whereas if I have really good static pictures, it seems to help me better. After incisal edge, we need to have an understanding that the second component of crown length is the gingival tissue. And so if we find our incisal edge and we want to have an 11 millimeter long tooth, that's where the tissue needs to be. And so when we think about Brian's case that I just showed you, when I found his incisal edge and measured north, we were only at 8. And so to make it normal, we had to bring the tissues up, right, to have a normal sized tooth. And then the second component of this is making sure the tissue levels of 8 and 9 are identical to one another. They have to be twins, because you can look at one central and see the other central at the same time. If it's irregular, it looks bad. If we draw a line from our central over to our canine, we want to see the lateral on the line or slightly incisal to it, but never above the line. If the lateral penetrates that line and is higher than the central and the canine, it looks off. Okay, so what's interesting, if you look at her, the height of 7 and 10 aren't exactly the same. It's not that noticeable because you can't look over here and here at the same time. So laterals have to be first cousins. They don't have to be twins. All right? And we can get away with that. Papillary contour is important. We don't want to see black triangles, so we'll talk about that a little bit. But in a healthy situation where there's no bone loss and everything's where it needs to be, the apical aspect of the contact point of the central usually is in about the center of the tooth, and we want the tissue filling that in. And so we've all heard Tarno's study from '92. You know, as we start losing bone, or that distance from the bone to the contact point is greater than 5 millimeters, you're probably going to have black triangle. So we either got to fix the bone or we're raising the contact point up. All right, but that's a great study to review. I think it might be the most quoted study in all of dentistry, and it's like this little page-and-a-half thing, you know, that's brilliant. But what's interesting is when we start connecting the dots of tissue that has symmetry, it often follows the curvature of the smile. And so we start seeing these harmonious lines that we don't see, but we see. Right? When it's not there, there's something distracting about it. So the more we can see the asymmetries before we do the case, the better chance we have of fixing those problems. Now we look at width relationships. We assign a value of 1 to the mesial distal width of the lateral. The central should be 1.6 times the width of the lateral. And the mesial third, remember canines are two-faced. We see the mesial third from the facial. The distal 2/3, because it's turned, is more along with the premolars. But this is the golden proportion that's all over nature. And, you know, we're not going to make everybody 100% this. You know, you can have people that are a little more central dominant. But if people are missing teeth or they're diastema, it's a great principle to go back to. And all of the digital planning softwares have the little golden proportion template that you can snap in there and measure, which we will do. And then the last one that I think is critical is this width to length ratio. And we know teeth are taller than they are wide, but just for easy math, if you had a tooth 8 millimeters wide and 10 millimeters long, this is actually longer and wider than that, but the point is the width to length ratio is about 80%. And what I will tell you for sure, my practice is rampant with what I call boomer disease. And boomer disease is somebody who's coming in for an aesthetic solution whose mouth is unattractive because of underlying functional issues. Right? I love these cases because we get to do occlusion stuff and aesthetic stuff. But when they have occlusion issues, usually the tooth's getting shorter, and what they don't like is the tooth starts to get square. And you got to find out where you're going to get the length. Can you lengthen it incisally, or you're bringing the tissues up, just like Brian, or are we doing a little bit of both? Right? But we're trying to get a normal sized tooth in their face. All right, so now, that wasn't too painful, but now we're going to go to occlusion. So everybody take a sip of your coffee, because caffeine's required in this. But we have things to think about. Condylar position, centric stops, anterior guidance, envelope of function, how to manage overbite and overjet, angle of guidance, posterior disclusion, vertical dimension, neutral zone. I'm going to do this in about 10, 15 minutes, but just so you know, this was a 3-day seminar, seminar 1 that I used to do with Dr. Dawson. It was, this is a big discussion, but we're going to hit the high points of it. But we need to understand some basic things about what we're trying to do with occlusal goals. And it's not to pass a board or like we were all taught in dental school. It's because occlusion is about managing force. That's all we're trying to do. We're trying to load teeth in a way that on closure and try to unload certain teeth in excursions to maximize the ability to control force. And if we can do that, our restorations are likely to last longer, the patient's likely to be more comfortable, less TMD type situations can potentially happen. Right? That's certainly not the only way somebody gets TMD, but it's a factor. And a good understanding of occlusion helps us with all these types of patients. So let's understand it a little bit. The great news for us, if there is occlusal disease present, it's visible. Like it's not like we do have to do a blood test to make a diagnosis, right? We're going to see where, it's probably the first thing we see, but teeth that are loose in the absence of periodontal disease are being overloaded. And so I would highly recommend you get your hygienist to look for this because it's more common than we think. Teeth that are changing position, like all of a sudden the lower incisors start crowding or spaces start opening up, is a sign of instability. Abfraction, some abfractions, some can be toothbrush or toothpaste abuse. But what I would say is the ones that are more toothpaste driven, those lesions are more U-shaped. The occlusally driven ones are more V-shaped, and you'll often see a wear facet on a tooth. Split or broken teeth, fractured restorations, sore muscles, and some TMJ dysfunction. All right, those are things. If things are going on like that for your patient, then thinking about reorganizing the occlusion is probably a good thing to do. Key point, the first one. I love this. This was classic Dr. Dawson. But the enemy of a good occlusion is when back teeth rub. So when we have a scenario that somebody can slide around and not rub a back tooth, usually muscle activity is a little bit lower. Conversely, what we know is if we slide around, I'll show you the EMG studies in a minute, but if we slide around and muscle activity, we slide around and rub on back teeth, muscle activity is higher, sometimes significantly. Now why? And we have to remember that we are designed to chew. That's what this whole masticatory system is about. And what we know is that if we can take a bolus of food and put it between our teeth, depending on the consistency of the bolus, when we bite down on it, the teeth are going to get pushed into their sockets where there are mechanoreceptors with greater intensity. And studies have shown us that if you eat something like Jell-O and you bite down on something, there's very little excitation to the system. But if you were to eat something denser, it's going to have higher levels of muscle activity. So, if tonight you were to travel with me to Richmond and we were to swing by my mother-in-law's house and we let her cook us up a steak where when she's done there's not an E. coli alive within thousands of miles, like she cooks that sucker all the way through, if you can get through it and put it in your mouth and you bite down on it, within about 2 nanoseconds, every muscle from the top of your head to your toenails are contracting. And you're not thinking about it, but I want you to just think about the pressure of a tooth posteriorly indicates how many muscle fibers are called into play of the temporalis master and medial pterygoid muscle. It's fact. So think about this then. If you have a patient that has a good disclusion pattern and you now put in a zirconia crown on that molar or premolar that now rubs, you check it on closure but you don't check excursions, what do you think zirconia to enamel does to the neuromuscular system? It dials up the thermostat, okay? So this is the classic study by Williamson and Lundquist. who used electromyography to measure the temporalis and master. He used bite splints and natural dentitions, but if you have a good clean occlusion where you can clench from here to here and then slide and no muscles bump, no teeth bump, you're going to see the temporalis and masters basically shut off, about an 80% reduction. Now, I got really into this in the 90s when I was learning about this and bought an EMG and started measuring my patients. And this is pretty classic of what I would see over and over. This is a patient clenching and sliding right. So from here to here, he's clenching, and he starts to slide right. He's in a group function, bumping into those bicuspids in the second molar, and you see a sustained hypercontraction of the temporalis and mater on that side. Now, this is the same patient about 4.5 hours later when I've got him in a provisional, and I've got him hitting equally contact all the way around. Now he slides, and he's off the posterior teeth, clenching from here to here, and now he slides, and those muscles go quiet. So I got looking at this and looking at this and looking at this, and got excited and was talking to Dr. Dawson about it, and finally he just kind of said, you know, you can probably stop measuring because we know this, right? Just all you need is a burr and, you know, some articulating paste and just clear out and stop the insanity. So I did. But this is what we see over and over. So our goal, if you look at this picture, is that if we can start in a healthy condylar position and close and have equal intensity contacts all the way around and slide and have no rubbing of back teeth, that's generally what I'm trying to do with my restorative patients over and over. Lots of study by Bob Kirstein. These are the more recent ones using the T-scan EMG are showing the same thing. So worries me a little bit because there's some philosophies out there that are questioning this. I just don't know how we throw all this research away. It just works. All right, we talk about condylar position. I already had a question about making sure the joint's healthy. And again, our supposition when we're doing orthodontic surgery, equilibration, or restorative dentistry, anything permanent to the teeth, we're going to have gone through some hoops to make sure that we have the condyle seated in centric relation, right? And centric relation, by definition, means there's a properly aligned condyle disc assembly. Now, does that mean we can't restore TMJ patients? We're not really going to talk about that today. We can, but it's going to be after they're stable, whether that's splint therapy or surgery or whatever the mode is. Just do not try to do permanent dentistry when this is breaking down, because it's like working on a patient on quicksand. There's no stability. But Dawson's definition, the relationship of the mandible to the maxilla when the properly aligned condyle disc assembly is in the most superior position against the eminentia, irrespective of tooth position or vertical dimension. We're talking about getting the lateral pterygoid to completely relax, let the condyle slide up till it can't go any higher, and it's a superior position. We're not jamming the jaw back, we're just getting the condyle up with the disc. And again, there's maybe some differing opinions about that, but that's what I've kind of hung my hat on for a very, very long time. Now, I mentioned being able to scan in CR and MI. And in Brian's case, I scanned open, right, because I was going to change vertical. Most of the time, what I will do if it's a fairly normal occlusion and I just want to see, I'll use a leaf gauge and I'll add a number of leaves to make sure the back teeth aren't touching. Then I'll take leaves away until I find the first point of contact, and then I add one leaf back till it's barely apart. And I'll scan them there, and then we'll scan them in MI. And what is so powerful with where we are digitally today, this is the iTero, is watch me. I can toggle between MI and I can toggle between CR. So I'm toggling between the bites, and I'm zooming in on where the first point of contact is, and you can see right back here, the distal of that molar is where the first point of contact is. I want to see if there's any evidence of a sign of instability, and when we take the color away, you can see the facet right where they're fiddling between CR and MI. So again, in the analog world, I had a really hard time showing people that. You know, I would show them a hit and slide on the articulator, and they'd be like, great. You know, they didn't know what the hell they were looking at, you know. But this, they can kind of know that I've scanned in a joint position, I've scanned in their own bite, and they can see exactly what they're doing and maybe why they're getting headaches, why that tooth's sensitive, whatever is going on. But right now where we are is CareStream will allow you to do this, iTero will allow you to do this, Trios will not, PrimeScan will not, but trust me, all these scanner companies are pushing each other, so I think it won't be long before, if you have one of those other scanners, you'll be able to do this. It's a great little multi-bite feature. And there's, of course, the first point of contact. But the main reason that I care about centric relation is, remember, I don't want back teeth to rub. And if I build an occlusion where the patient's maximum cuspation is forward of CR, if that patient has the ability to clench, you have a condyle now that's basically sitting on the slope of this eminence, and you have the master medial pterygoid and temporalis all pulling upward, while the relatively small lateral pterygoid's trying to hold it there. So visualize that if they grind between CR and MI, they're rubbing on back teeth. That's why Chrissy's previous scan, tooth was wearing. The CR interferences are going to be on the mesial of the upper and the distal of the lower. The muddle rule that we all learned for boards 4,000 years ago, right? The muddle rule. That's where CR interferences are. So if you care about posterior disclusion, if you care about lowering muscle activity, I want to organize the occlusion in centric. All right, so let's do this quickly. These are going to be the 5 requirements of occlusal stability based on what I told you. And number 1, which is pretty simple, is again, if we're working in centric relation, condyles are seated, I want the jaw to close, and I want 14 teeth hitting 14 teeth with equal intensity contact, right? Usually the lower buccal cusps are landing on a marginal ridge or a central fossa. The upper lingual cusps are landing on a marginal ridge or central fossa. The cusp tip of the canine is going to be usually more in this area, kind of on the mesial side of that canine, and you want contact with the lower incisors. If you want a little lighter, that's fine, but we don't want those out of occlusion because they'll erupt. So we want whatever load the patient can generate, let's distribute it throughout the whole mouth, right? And that's a good, safe way to do it. And then the other thing that I want you to think about is if your cusp tip is landing on an incline and not a marginal ridge or central fossa, it's not going to be as stable. We want it to land on a flat surface. Otherwise, they can kind of slide past one another.
Basically, you measure that with 200 microns.
I'm using the AccuFilm 2, and I'll show you that. And that's like 7 micron. It's really thin. But if you want to start with something like Madame Butterfly that's a little thicker, that's fine. But when I'm dialing it, I want to be much closer than 200. Yeah. 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 Okay. Now the second thing is we've talked about this and I want to introduce a new concept to you, but we definitely want to have anterior guidance, which when we start sliding laterally, we want to have immediate disclusion of the posterior teeth. Laterally, canines are going to carry the load most of the time. And in protrusion, centrals, if the centrals are short roots or one's an implant, you want to do centrals and laterals, right? But that's what we want to do. But what I want you to think about, anterior guidance is the path the lower incisor travels up to the incisal edge inside out. So it's the patient moving on their teeth. The other part of this rule, though, is we want to have harmony with envelope of function. An envelope of function is the path the lower incisor travels outside in. So when we lay back and we're sliding around, that's one thing. But when we sit up and start walking around, the jaw starts going like this as we chew and speak. And that's like a fingerprint. We can't see this on an articulator, so we have to check this in the mouth. And I'll give you a scenario that you may have experienced. Let's say you're focused on this and you put some beautiful crowns in canine to canine, and the marks are great and on closure, and you go into excursions and the lines are where you want it, and the patient, stands up and gives you a hug and your high five, one of those days. One of those great days. Next day you get to work and first patient's late and you got an emergency, and then all of a sudden this patient calls and says, patient front desk goes, she feels like there's somebody else's teeth in their mouth. I'm like, oh my God, so have her come in. So now you're coming in. So I wanted you to think about how you're going to evaluate this, because the first thing we think about is, what are you feeling? She says, they're just banging. I think they're just high. So we lay the patient back and we check, and the marks are exactly like what we saw before. So if we don't understand envelope of function, our choice may be, well, maybe I should just take them out of occlusion, which is not what you want to do, right? What we have to remember is with front teeth, we have to also check them sitting up. And I even like to let them lean forward a little bit, because if they close and the mark is here, their jaw is often seated when they sit up in what prosthodontists call the alert feeding position, right? Sometimes the jaw postures forward a little bit, and you'll see a mark, a skid mark, forward of it. And I like to do my centric stops in black and my long centric, or my patient sitting up marks in red. And if I see any red skid forward of my black mark, I take a football-shaped finishing diamond and I increase the concavity. All right? We do the same thing in our provisionals. So we want to give the lab that contour, but there's times when the lab will steepen it, right? And that's what's happening. Your path is just too steep, not for anterior guidance, but for envelope of function. So we want to maybe lay them back, sit them up, and if you do those things, now the patient can close and the lower incisor is traveling and it doesn't touch any porcelain until it gets back to the stop. So if it's bumping on something, it can drive them crazy. The other thing you can do is put your fingernails on the teeth with gloves on and just lean them forward and have them bite. And if there is a long centric interference, the tooth's you'll feel some fremitus. But don't grind the centric stop. Find that little place forward of it. Is that clear? Okay. So again, I want you to think about this as an outside-in movement. And what we want is we want this lower incisor to be able to just clear until they get back. There should be no contact forward of where their centric stop. Steep enough to exclude the back teeth, anterior guidance. Concave enough to be in harmony with the envelope of function. If we do that, you're going to have really comfortable, well-functioning anterior teeth. So think about inside out. This is anterior guidance. Think about outside in, envelope of function. If we build those two things, then we're going to have it. Okay? So condylar position with good centric stops, anterior guidance, and harmony with the envelope of function. And the rest of this is easy, because we don't want any teeth in the back to touch in protrusion. They should all disclude. We don't want any teeth to touch on the balancing side. And again, notice this is a tricky one, because when we go into a right working movement, we got to get past the longer lower buccal cusp has to get past the longer upper lingual cusp. And we get help by that, because as we go into this movement, the condyle on the balancing side is coming down the articular eminence. So we have help from the condylar guidance on the balancing or medial-intrusive side. And then Dr. Dawson gives us the permission for something. Most of the time we're going to have canine guidance, but there's going to be times when you can't have it. What if your canine's an implant? What if your canine has a huge post in it and is a weak tooth, and you don't want all the load on it? What if the patient is class 2 and won't do jaw surgery? They don't even touch. Then we have to go to a group function, right? And so in a group function, we just are going to choose the teeth that are going to carry the load with the understanding that muscle activity is going to be higher. So in that scenario, we're always going to finish with a night guard, right? And give them an ideal occlusion in a guard. All right, that wasn't so bad, right? We had to do that. I'm sorry. But let's do that, and we'll do our digital goals now, or digital tools here, which is why you're here. But I want you to have some context for how we're using all of these things. So as we mentioned, there's 3 pieces to this. data acquisition devices, digital cameras, intraoral scanners, digital x-rays, CBCTs. We've got something like ModJaw now, which is jaw tracking. We've got output creation devices like 3D printing and milling units. Again, how many people have printers in the room? All right, so a couple. And then the importance of software, which we're going to spend some time on. The thing I want you to see, and I'm going to show you a lot of workflows here, and I want you to realize that while we have a lot of these pieces, it's possible for you to have a scanner and a printer and outsource the design. So it's possible that the lab could have this software, or some sort of company can do it. I mentioned we're getting a mill. We bought a mill, and one of the things we're going to utilize initially is 3Shape has something called 3Shape Express, that if we're going to be designing some crowns, we can take our scan, send it to 3Shape, and they use AI, and we get a design back in 60 seconds of a crown that we can open up in our 3Shape and still manipulate it, but margins are marked and everything's basically there. So there's services like that. And how much do you think this AI costs for that design service? What do you think? For one unit, what do you think you pay? $1. So some of the AI stuff is getting ridiculously cheap, and it rather than having my assistant do it for 20 minutes, it makes sense to utilize some of these services. But same thing with splints. For a long time I didn't have software. I scanned, I sent the software or the splint over to Bayview, they designed it, and we printed it. So think about that. You may decide next to get the software but not have any output creation and outsource that. So who's going to own the printer? Who's going to own the milling? Most of us are not doing a lot of milling in our practices, so we outsource that. But as you go through that today, I want you to think about that. In your mind's eye, it's important to think about what's the logical path for your practice. And I'll give you some tips about that towards the end. We're working with about 400 docs, and we've talked to a lot of different people that are going through this process now. And what's maybe a little arrogant of me when I started all this is I thought every dentist would do it exactly like I did it. And it's just, every dentist does it a little different. But you can find your path through. Just don't do it all at once. So let's talk about scanners and data acquisition. Getting good people that will help you with this is so huge, because one thing is for sure, just like the analog world, if you start a crown, trying to make a crown off a bad impression, you're not going to get a good crown. And so data acquisition is key. Great photographs, great clinical scans. You need to know, we have both Trios and the iTero in our practice, and what the team members have to remember is iTero has a different geometric pattern that you're supposed to follow when you're scanning versus the Trios. And it's important that you follow their recommended path, because that's how it's trying to stitch the data sets together. So, once a year we have our local rep come out and just kind of standardize our team to make sure we're not getting lazy, because it's like anything, it's just easy to start developing your own way. It may be a little faster, but may not be best. And similarly, when you start getting into photographs, one of the things I'm most proud of is every photograph that you're going to see in this presentation, I did not take. It's one of those ladies. So we work hard on it. I'm picky about our photographs. I look at every photograph series that they take, and they learn quickly if something's not right, we're going to retake it. So they learn to do it. But getting these photographs are critical for what we do. And then depending on whether you have CBCT or not, when you're going to do that, that's another point of discussion. But let's just look at some tips with intraoral scanning. And the first thing that I'll say is there's a few things that can be helpful when your team's learning. These little Optogates that hold the cheeks out of the way can be helpful to them. But if you've got somebody struggling, what I want you to watch Kristen here, she's looking at the screen about 95% of the time. And often people that are struggling, they're looking in the mouth. They're trying to just follow it, and they really need to be able to manipulate the wand while they're looking at the screen. That's one of the best practices we see with scanners. The other thing that I'll just say is that I have gone through a transition of how I retract from analog to digital. And I was somebody that paid attention to Bill Strupp, and who I thought was one of the best preparer of teeth and tissue management of anybody, and he practiced in outside of Tampa. And then I heard Spear, and a lot of the people were 2-cord techniques. And the idea was you'd put in a small cord soaked, something like Viscostat or Hemodent or something like that. You'd put a large cord on top, and then you would pull the top one, and the bottom one would keep the curvicular fluids dry. And your goal was to get impression material past the margin, right, by about 3/4 of a millimeter. So when the lab guy was looking at your die, they could see root apical to the margin so they could trim it. But what we have to remember is when we're scanning, you're never going to see this wall. The scanner can't see that because often the tissue's right here, so you're never going to get a scan. Until we're doing ultrasound or something, they're never going to see that. So scanning is line of sight. Now the good thing about scanners, though, is scanners can see color. If we give them not just an STL but a ply file, they can see what tissue looks like, they can see what cord looks like, they can see what tooth looks like. So as long as you have a line of sight and they can see the margin, then that's a good scan, right? So we don't have to retract as deep. So I actually went to a single cord, right? And our option is we could leave the cord in, which I do a lot of times, and as long as the cord is apical to my margin and I'm looking in and I can see circumferentially and the tissues are out of the way, you're not going to miss that scan, right? You're not going to miss that scan. But this is what you have to look out for, because this is exactly what we're talking about. Notice we can see our margin really pretty well all the way around. But do you see right here where the tissue's kind of leaning over? If you send that to that and they trim that, it's going to, your tooth is under there a little bit. So your choice is what? You could put a bigger cord in there and push it out, or if you have the ability to just cut a little way, we'd pick up the laser right now and trim it, or if you've got an electrosurgeon you can trim it. You could take a burr to it and just trim a little bit of way. But it has to be line of sight, and if it's line of sight. Similarly right here, if you scan that, see how we're just maybe missing that margin a little bit? You've got to be able to see. If you can see it with your eye, your scanner's going to see it. So just look tooth by tooth a little more carefully, and we don't have to do this as extreme, okay? One cord, save a little time. The other keys with this is, remember, we want to keep the site bone dry. If you can see it and it's wet, you'll often look like a good scan, but saliva can change the optical properties of the scan, like the way the light penetrates through the liquid can affect its wavelength and all that stuff. So it needs to be dry. Use a single cord large enough to push the tissue away. Line of sight is key, and don't take the cord out. Right? So that's one option. And I do this, I can't tell you when I do what, but about half the time I leave it in. Half the time I'll pull it out.
Excuse me, quick question. If you're using Reshape to scan, and I send that scan to you, you do not use Reshape lab software, you're using Exocad. Can you see my scan in color, or you see it in black and white?
So my understanding is, I don't use Exocad, but my understanding is, with where we stand right now, Exocad can see color in anything. 3Shape, up until recently, if you sent a iTero scan and you put it into 3Shape software, it will only show it in black and white. But my understanding is that changed this month. And so we're using Trios when we do restorative. So, but that was a frustration, because I would tell Lee, our lab guy, I'd say, look, use the ply file, the PLY file's color. And he's like, it won't show up in 3Shape. So we bitched about it, and I think they've changed that. So all these companies are realizing that the systems need to be more open. Yeah. But the question that's important is, If they're using your STL file from your scan, it's always black and white no matter what the software. But in every scan, you also have the ability to have a PLY file that they can pull out of the data. The PLY file, PLY, is color. So ask them to use the PLY file, and then you'll know, okay? And I think that's really important. And you know, it's silly, but a lot of the labs, you know, fought me on this. Why? Because they're used to looking at stone, you know, and I'm like, but why would you look at stone if you didn't have to look at stone? Like, you can see what gum tissue looks like. You're going to trim the margins better. Once they get used to it, it's good. But, you know, it's like a lot of things. It's just a different thing. So again, if you use a larger cord and soaked, and again, probably the time that I might leave the cord in is in those situations, thinner periotypes, the tissues are really tight and healthy, and I just don't want to, I can't get the cord apical to the margin without feeling like I'm tearing it up. You know what I mean by that? It's just a tight one. Lower incisors, things like that. So I'll just put one in, let it sit, and then pull it. And you know, if it looks like that, we're going to get that scan, right? You can see it all the way around. So you can decide which way you do it, but we want to see, they want to see it in color, where everything's retracted, where everything's clear. All right, so just going back to it, OpterGate's a great key. Get them to look at the screen about 90% of the time. And then the last piece that you need to remember is the labs a lot of times will, not the labs, the scanning companies, they make a big deal about speed, right? Because that's a big selling point. And they will teach your team to just see how fast they can scan the teeth. And what I would tell you is get them to spend about 20 to 30 more seconds and get the data. Get the palette, scan all the way up to the height of the vestibule. You want your scans to be like a, do you remember in dental school when you were taking alginate impressions and they like terrorized you because you couldn't get all the, you want it to be like that. You don't have to terrorize your assistants, but you need the data. Why? Because if we do a diagnostic wax up on this scan, and we're now making our prep reduction guides or our provisional matrices, we need that to rest on the tissues. And if it's not there, it's a problem, okay? And then if you have a lab they're printing for you, make sure they don't cut that away. Right on there, I want the palette. I want, you know, otherwise they just cut it and it's kind of worthless to you. Everybody's trying to save a buck. All right, so let's just look at how we're doing it. I'm not going to show you the whole process. This is with CareStream, but it's just scanning. We scanned the upper and lower. Now we're just scanning maximum cuspation. So you see how fast that comes. We'll scan both sides, so that locks in. And then she can pull that up in the multi-bite and then put in there maximum cuspation so we know what that bite is. And then there's several ways to get CR. For those of you that have been to Dawson and Pankey and learned Dr. Dawson's bimanual technique, you can use that with a Lucia jig, or you can do a ball of composite. This is what Pankey's currently teaching now, which is a very simple way with a leaf gauge. But if we start with a leaf gauge and put it between the teeth and just have them slide forward, back, and get them nice and relaxed, and they can squeeze a little bit and make sure there's no tension or tenderness. This is a 2 or 3 minute process. I'm going kind of fast, but to the point of, you know, if you are slightly open from the first point of contact and they're gently squeezing there, we can now scan that. The danger with leaf gauge is the potential for a little distalization on deeper bites. So just be careful with that a little bit. But I think from the standpoint of getting a CR record, it's a very easy way to do it. Right? So that's how we're doing that. And again, I've shown you the slide. In terms of CBCT, that's the other thing that we often use. We've got the CareStream 9600, which I really like. It also has a face scanner on it, so we can get intraoral scans and face scans and the CBCT all sort of working together. Give you an example of that a little bit later. But you know, once you start using this, it does forever change how you look at teeth, and being able to pay attention to the thickness of bone on the buccal plate and the lingual plate, being able to volumetrically measure airway, for us to be able to see joints and look at not only where it is, but the health of the joint and whether there's condylar breakdown or not. And you look at that joint compared to this one and where it is in the fossa, and you don't have to be a rocket science to know this one isn't healthy, right? So scanning for this is an important part of our workups. And I think this might be a pretty good place because I want to get into software. Actually, let me do printing first, and then we'll do software. This will just take a second. So with output creation, I'm not going to talk about milling units today, but I do think 3D printing is important. And the first printer that I got, as I wasn't sure I was going to like it, I wasn't sure I was going to do it, I thought it was going to be ridiculously complicated, so I spent about $3,000 on a printer that doesn't exist anymore. It's called the VeriBuild. It was printed about 2 different resins. You know, it printed models. It took a long time. It was slow. It was very accurate, 50 microns. But it just wasn't very broad. So as soon as I realized that printing is actually very simple, I realized we needed to move on. And this still hangs around, but we don't do much with it. The 2 workhorses in our practice is the Accurita Soul. It was sold as the VeriEcho, but this is the Accurita Soul, which is a great printer. And then we have the Asiga Max UV. The other big one on the market is SprintRay, another great printer. I think SprintRay and the Asigas are really probably cornering the market right now. SprintRay does a little better marketing at dentists, but if you go into high-end labs, this is kind of the workhorse. It just never breaks down. The thing that I would tell you, if you're in the market and thinking about it, these printers are about 10 grand, but what they do is they print everything. And you want a broad spectrum printer that can do the model work, it can do orthotics, it can do surgical guides, it can do provisional materials, it could do inlays and onlays if you're doing resin ceramics. And now, you know, these printers will do that for you. And so this is the one that I've been really, really happy with. Okay, now we take a break. Let's take about 10 minutes, and I may give you like 2 little shorter breaks throughout the day just to keep it moving. Yes, and then come right back.
So we have live stream attendees, and they actually had a question, Dr. Cranham.
Okay, sure.
This was from earlier in the day, but Morgan was wondering, can you use 3Shape software with the scan taken with the iTero scanner?
Yeah, great question. So I should have told you that. So both the 3Shape lab software and the Exocad lab software are completely open systems. So remember, they're owned by laboratories, so they have to be able to accept any scan. So if you're working with a 3Shape premium lab software or Exocad, any scanner that you're using that can export an STL will work. Even Sirona's Prime Scan now. It didn't used to be that Sirona let you send scans places, but the Prime Scan will work with these other systems as well. Okay? All right, let's take a quick break, and then we'll keep rolling.
It's seminar 1 in an hour and a half.
Yeah. How about that?
Can I use your
Yeah.
break? Ask a question. So majority of the patients when they do post-ortho, you do clinical exam, how you do like a moderate, like a wear on the second
job coming back. All right, is there any questions before we move on and talk a little software, and then we're going to start going through cases? Oh,
We have a couple online
okay,
questions.
cool.
Okay.
See, the online people they're not
online.
sitting here, so they're braver than y'all. Go ahead.
We have, with the one chord technique, are you using a larger chord than if you did the two chord technique? If so, what size chord for anterior and posterior?
If the periotype's a little thicker, I do use a larger chord, and it's usually a number 1. And if it's a little thinner periotype, then probably a 0.
Cool. And then one office has the Asiga Max. Are we able to print pinky splints?
Yeah, so we're going to talk about that.
Okay, perfect. All right, that's it for now. Thank you.
All right, good. All right, so let's do a little software. And again, I want to spend a little time on it because I do think it's the missing link for a lot of practices. And for whatever reason, as dentists, it's like scanners and CBCTs are like really tangible things that we know we need if we're going to go down this road. And a printer or a mill is like something that sits on a desk that we know we need. And software, it's like, doesn't seem like it's that important. But in reality, it's probably the most important decision that we make because it's how we manage the data. So there's couple players right now. The 3Shape Premium Lab software is what we're using, what Drew's using, and it's a great software. And again, this is not the Trios. When you hear 3Shape, a lot of people think it's what comes with the scanner. This is actually software the lab would buy. All right, so virtual articulator, Splint Studio, be able to wax, make crowns, all that stuff. And then Exocad is doing a really good job right now marketing to dentists, so you hear more about it, but it's basically the same product and potato, right? I mean, some people love one versus the other. It's funny because Lee Kalp, who is a 3Shape guy, who's does a lot of our lab work for me, he got Exocad in there, and I'm like, so what do you think? He goes, I hate it, because it's just different. It's not that it's bad, but once you learn the software and the buttonology of it, you go into something else that feels different. And so, and the same experience on the other side. In our training, we actually have the video training for both, so you can kind of decide. The other one that I'm hopeful for that's slow on the emerging is ZimV has a product called RealGuide that is a fantastic implant planning software that we use that now has full suite, that also has a virtual articulator and some of these things. Don't buy that yet. The virtual articulator sucks. It's getting there, but their design people or the company they bought that has all the virtual articulator and all is based in Lake Como. So if you would like to write a letter to the company and recommend that I go there for a month and help them, I'd appreciate that, okay? Paid to Lake Como. All right, so again, visualize with me that you've got one software that comes with the scanner that replaces the traditional impression materials. And then the second software is going to replace your model trimmer, your articulator, your waxer. And again, it has all the dental capabilities of all lab specs. And you need it if you have the desire to do virtual articulation or wax ups, okay? And so just be clear on that. This is my family, beautiful family. And Bruce mentioned that I have a son I wrote a book about, Cornell. And you'll hear about him a little bit later. But what I will say is right now, as he was born at about 1 pound, 2 ounces, addicted to crack cocaine, had a really rough first year of his life. And my wife was his occupational therapist at the Children's Hospital where he was on a vent-dependent unit. And he started to wean off the vent, and we brought him home with us. And so initially it was just as a foster child, and we thought his parental situation would get better, and it didn't, and we ended up adopting him. And what's transpired is just kind of this amazing just recovery and inspiring all of us in the process. So that's why I wrote the book. The reason I'm telling you this now is when he finished high school, he definitely still had some developmental delays and on the other side of the bell curve from his sisters, and college was not in the cards. So he went to work at a dental lab, actually got tested, and he tested pretty high and potentially being a lab technician. So he went to work for a dental lab, and when you go to a dental lab, you get thrown into the plaster room first, and so he learned how to pour models and mount models. And when my daughter got out of dental school, or was going to get out of dental school, I knew we were going to need a little more help in the office. So he came in and started doing all our mountings, because we mount on articulators and all that. So, this was probably about 8 or 9 years ago that he came in, right when she was kind of starting dental school, and it was great. But then I started to enter the digital space, and I was so afraid that he was going to get left behind. Like, I was terrified. I just wasn't sure. What I forgot, he had like 22 years of experience with games. Like he grew up with a screen and a mouse and all that stuff. So when I sat him down, here I was, 60-year-old Jhon, scared of the computer, and I'm like showing him what he's doing. He's like pushing me aside. He's flying through the screens. What's over here? What's over here? So anyway, I'm telling you this because he does all the mounting in our practice. He does a good bit of the printing. And while he drives and is completely self-sufficient, he's never going to do quantum physics or calculus, right? So there's delays there. In your practice, you do not need somebody that can write code to work this software. And the other thing that I'll tell you is in some of the practices we're working with, a lot of times the best assistant you have isn't the best for this. Like, they're better chair side. Sometimes the assistant that's a little slower chair side might be great at this. So think about that, because it's not rocket science, but you do have to have the type of person that likes working on a computer that can do repetitive tasks. And so what we're watching him do now is mount a case. So when I want a case mounted, he'll open up 3 shapes. He picks the teeth that we're going to work on, and he just fills out the order form first. And once the order form's filled out, he'll go into the cloud and grab the scans. And this is just about real time. Okay, this is just about real time mounting on a virtual articulator. And so the thing will open up, and the first thing that pops up is this platform. Now the AI does this. You used to have to attach that maxillary scan to that platform and move it around, but now it just clips on there. But now it's on that platform. He's going to pull the incisal edges up. And remember, the mandibular scan is going to come in wherever you scanned it. So there's no alignment of that. And so go ahead and bring in the mandibular scan. It's going to be coming in where we scanned it, which was centric relation, and then he turns on the articulator and it's there. So what used to take him about 3.5 hours over 2 days and come home at night covered in plaster or mounting stone now is about a 5 or 6 minute job in my practice. And there's a lot of times that when we are doing new patients, I'll do my exam first, we'll usually scan second, and then they'll do the photographs. So if there's something weird in the occlusion, like at that exam, and I want to look at it, I'll just turn to him and I go, hey buddy, put this one on an articulator. And he's got it on the articulator before they're done taking pictures. It's pretty cool. Now I don't treatment plan it that day, I still bring him back for consults, but it does allow us to view patients in a way that we more efficiently. Similarly, when we'll show you a splint studio later, but splint studio is basically the same process and how we mount. We can design splints in about 20 minutes. If I've got a TMJ patient in the morning that's hurting, I can have an appliance for them that afternoon. So it allows things for us to move in ways that we couldn't. This was the study that Drew actually found in JPD. It was 2015 that was comparing the Coyce facial plane analyzer, which is based on this Bonwell point, to earbows. And essentially, both averages were basically the same variation. So I was shocked by this because when I started this digital using this thing, I can remember Pete Dawson, banging his fist saying, earbows are more accurate. You're going to be closer. Don't use that DFA. It's trash, all this stuff. And so I just knew when I was using the DFA on the virtual instrument that he was going to come at me in the night and strangle me or something, But this shows, this is the science, and Pete always supported the science. And this 100 millimeters is what we're talking about that absolutely works. Like I say, I've got this now doing it since 2017. I have found zero difference in accuracy when mounting using this 100 millimeter Bonwell point average versus the Earbow average. In fact, I think digitally is more accurate. And I don't think it has anything to do with the face bow. I think it has to do with the bite. Because in the analog world, there's things that can happen to those wax records, right? I mean, just how it fits in the models, a bleb on the stone, whereas if we're scanning in CR, it's locked into that position, which is great. So again, just to keep it clear, we're going to mount the maxillary cast in a 3-shape using this Bonwell point. The mandibular cast is going to appear wherever you scan it. So if you bring in the MI scan, it'll be there. If you bring in the CR scan, it's going to be there. Your cast will be mounted accurately in minutes, and no friggin' wax, which I like getting wax out of my life because I've spent a lot of time monkeying around with wax to get a CR record. This is easier and faster. Now, we had a great question about the plane, so let's talk about this. So if you look at a patient and you're looking at them and the maxillary occlusal plane is level with their eyes and everything's symmetric, you probably don't need the photograph, right? Because when it comes in, it's going to read that occlusal plane and line it up for you. So I find that to be very accurate when everything lines up. But as we know, there's a lot of people whose eyes are here and the plane is like this. And if the plane is level and like this, it's going to put it on the virtual articulator like this, and that's the problem. That's why when we put a face bow on somebody or a DFA, we're putting it in and then we're lining it up with the eyes, right? So we want the maxilla hanging on the articulator the same way it hangs on the analog or virtual articulator. So what we can do, the first option is to use this photograph and use the process of data stacking. You can use a regular photograph, but if you retract, you can, and I would recommend retract and having the teeth apart so you can really see the edges. You can really see the eyes. And this happens a little quick, but you will see it again. Essentially what we're going to do is pick points on the photograph and pick points on the scan, and the scan will become attached to the photograph. So when we bring in the articulator, the photograph and scan won't move, but we can move the articulator, so we can level it. So that's essentially what we're going to do. There's the points. You'll watch the scan now overlay on the photograph. And if it looks like this, you can see the cant. What we'll do is basically just grab the articulator right here. The scan won't move, but we'll level the articulator to their eyes. That's what we do. So now the eyes are level with the top of the articulator, and that will be aligned. So I'll show you that in a couple cases. So that's one option. If we want to go a step further and we have a CBCT, the CBCT is even cooler, and we're going to add some layers to it. But let's have scans, let's have CBCT, let's have a face scan and layer the data. And the cool thing about using this is with a CBCT, we know where the condylar axis is, right? So this is the closest way to getting to a fully adjustable type situation. So looking at it, there's the scans. We'll attach the scans to the CBCT. And to make it look just as creepy as we possibly can, we'll bring in the face scan. So that now moves. All right? And now we can take the articulator and line it right up over the condyles. So that's another way to do it. So that's pretty cool. Now the one thing with the CBCT that's tricky is you have to export the DICOM into an STL type environment. So there's conversions that have to happen. But anyway, if I go this route, I just let Lee do it. I just send it to Lee and let them do it. This is all 3-shape. Yeah, and then there's, you mean the transfer? Yeah, I don't know. That's when we get there, we just say, Lee, we sent it to the lab and he has all that. You can do that in RealGuide now. So I think the softwares are recognizing that that's more of a thing. This is what it looks like in RealGuide, similar with the scans on top of the CBCT, and then you can bring the face scan in. I don't like it quite as much because the face isn't quite as colorful, but you can still see the key points. And orthodontists, like you start interdisciplinary stuff, like surgeons, orthodontists love this because they can see how the bony parts affect where the lips are and all that stuff. So this is great for interdisciplinary type discussions. All right, now, so I will tell you this. If the software only mounted models and let me decide whether I can equilibrate or not, I would pay the money just to do that because that alone saves me so much time in my life. But it does more than that, as you'll see. But one of the biggest things to remember is that if you're going to work in centric relation and you close the patient down and they're hitting somewhere in the back and you want CR and maximum cuspation the same, we need to equilibrate. And if you went to Dawson or Pankey, a big part of what they train you is to mount models and then do a trial equilibration on cast to see after, when the front teeth touch, like if you've removed the slide completely, whether you've destroyed the posterior teeth or not. So you're locked in for about 30 minutes doing that trial equilibration. If you're doing this a couple times a week, it's a lot of time. Now in the digital world, what we can do is once we're mounted, what we can do is we can close the articulator down, and what happens is when we hit the first point of contact, the teeth just go through one another. So what I can do is I can close the virtual articulator down until the front teeth touch and say, okay, that's a good contact up front. Now let's look in the back. And in the back, they're penetrating through. And so what I can do is there's a slice tool that I can use to measure that. And so I know like that, if it's like 1.5 millimeters, that's probably too much to equilibrate. So now that I've just described that, let's look at this. Where did I put my flicker? Thank you. What would I do without you, Drew? All right, so let's look at it. So what I want you to see is the articulator will close, and you can see the pin changing as I do it. So it's closing on the arc, and it closes on that arc. I can hide the articulator, and I can look through, and notice how the blue lower model is starting to penetrate through, and I'm going to keep closing it until the front teeth start coming in. You're closing vertical. Yeah, you're closing vertical right now. We're closing the articulator. So we're going to close. But what I can start to see is that whole lower molar is practically penetrating through. So what I'm saying is that, and I'll show you how to measure this in a second, this is a huge time saver because I would have had to equilibrate all that away. So between mounting and doing the slice tool, it saves incredible amounts of time. Because here again, if you go back to that example of, hey buddy, go ahead and throw this on articulator, and I've seen a big slide, I know right now whether I think I can equilibrate it or not. And if I know I can't, I might bring up, how do you feel about ortho? You know, if I have to maybe consider ortho, would you consider that? I can start planting some appropriate seeds. Let's look at it a little bit more closely, a little more dramatic now. I'm going to close it down and just show you if we way over close it, you can see how the whole lower jaw starts to penetrate through. See in the lowers, obviously we don't want that, but we're going to back it up just where the lower incisors and canines are touching in the front. But if I want to measure, say, a specific cuspal area, I can slice right through it and then zoom in two-dimensionally, and you can see two-dimensionally how much that's penetrating through, and I can measure that. So in this case, that amount of penetration in that cuspal area is about 0.7 millimeters. So if we're doing 0.3 off each tooth, patient's 60 years old, that might be not so bad. But what if the patient's 20? You might not want to equilibrate. So we can make the clinical decision. Now, if I want to do a trial equilibration, can I still do that? Absolutely. I mean, I can still go in there and take it away. Again, looking at it just another way, these are the decisions. Can I equilibrate? Can I not equilibrate? Now, this is a case we're going to look at in a little bit. And the other thing we can do is close down to where we have the first point of contact, which is this case is in the bis. This is post Invisalign. If I don't want to equilibrate this, what I could do is I could take it through the model building software, and I can add a very specific base. So I'm going to print model, so it's got a base and it's got this little extension with 2 holes in it. And what's so slick about this is when we mount this with this little platform, all articulators now, there's a company called AD2, Advanced Dental Designs, that sell this little plate that has these 2 pins on it, and these plates will snap on to your articulator. So pretty much any articulator has them available, and if you want to go back to analog, we can go ahead and just pop these right on these little platforms here, and then the bottom is magnetic that will just snap onto your articulator. Now, why would we use this? Well, like for my daughter who's learning to equilibrate, we learn to equilibrate by equilibrating models. And even though you can equilibrate it in the virtual world, it's not the same brush strokes. You're not learning how to shape teeth. And so this just came into existence this year. I think it's an incredibly important step because we can be in the digital world, and at any point, if we want to go back to an articulate, a lot of times what she'll do with her cases, if it's an aesthetic case, she'll do her aesthetic design, but leave the interferences, and then go back to this and do the trowel equilibration, and that's how she'll piece her together. I've done enough equilibrations that if I see that I'm not going to destroy the teeth, I just equilibrate. I don't go back. Yes, sir.
Hey, Jhon, can you use that slice tool to measure negative space? You're showing the teeth like penetrating through. If we were able to measure the negative space, you could look at additive instead of just subtractive.
Yes. Yeah. And so, yeah, another way to think about it is, let's say it's an additive case. Let's say you're at the first point of contact, and I actually have an example of this, but let's say you're at the first case and you haven't designed yet, or maybe you have designed and you want to know how thick things are, you can do that. And actually that's what really the slice tool is for in the lab space, for them to measure things. And it's most of the time it's the thickness of things that are actually there, like copings and things like that. But this works great for both ways. You can take a snapshot anywhere and make a slice, and whether it's negative space or going through positive space, you can measure what you want. Okay? So again, once it's on there, marking that first point of contact. Just want to show you how accurate this is. I'm going to mark both sides and then show you where those first point of contacts are, and then remember where they were in the digital world. They're pretty much the same spot. So very comfortable going back and forth between the two. And then if we want to equilibrate, we can still do the things that we used to do in stone. Usually taking away inclines, leaving behind the little remnant on your cusped tip, marginal ridge, or central fossa. And we keep dialing this in until we start seeing marks all the way around. So we'll always equilibrate to centric first, get our contacts where we want, and then we'll work out our guidance. All right, so just giving you some time ideas here. So mounting cast, I would say if you're not mounting cast and you're trying to do big cases, one of the big reasons we didn't mount is because it's a pain in the ass. I mean, it took a long time, and then you're looking at it. It was a 2 to 3 hour process, and it wasn't easy. Like, it took a long time for us to get good at it in our practice. This is much simpler. So 2 to 3 hours versus 10 minutes. Finding out if the equilibration is the option. Well, you had to do a trowel equilibration, which 20 minutes, more like 20 to, closer to 45, where this is a 5-minute slice tool. If we actually do the trowel equilibration, analog, again, 20 to 45, digitally, because we lock it and we don't have to keep opening and closing, we're just kind of reshaping. It's usually about 10 minutes. And then if you are comparing a trowel equilibration on an analog articulator versus using the 82 mounts, it's going to be basically the same because you're still equilibrating. But as I said, this slide, if the $3,800 that it costs for 3Shape software, if this is all it did, it would be worth it. I would pay for it in a heartbeat. All right, tremendous time savings. So again, just looking at it, this is early pictures. I think I might have stolen this from you, but anyway. Just looking at first point of contact, what we're seeing in the virtual world versus what we're seeing on printed models in the analog world. But look at the interferences. Once you start seeing that it's actually the same over and over and over, you start to trust it. And I think that's the biggest thing we got to get over. I mean, I lost sleep in this transition because I just wasn't sure it was going to work. 2017. Now, when we wax, as I've mentioned to you, we're not really waxing. All these softwares, Exocad or 3Shape, has these tooth molds that you can choose from. And you can, if you want to have a smile library and let the patient choose. But when we're designing, what you want to try to do is take the mold and scale it into position without using like the rubber brush or because the more you mess with the contour, the more you're going to just mess it up. But if you can just scale it into position, you can do this kind of globally first, and then we can start moving individually. So this is visualizing a very minimal prep veneer case. So it's going to be primarily additive. And so I'm trying to just get this in position. It's a little bit of a rubber tooth there. I can make it translucent to see thickness. I could use the slice tool here if I wanted to. But once I get this into a shape that I like, I can grab that one and create a mirror image and go bink, and the other one's done. So this is fun, right? This is, again, real time. So, a veneer design with a little equilibration, 20, 25 minutes. And that's Lee Culp's anatomy or Matt Roberts' anatomy. And then from the standpoint of equilibration, I've shown you that. And then we also have all the excursive movements there. So we can see all the lines, get the lines where we want it, the dots where we want it, and move from there. Okay? So as we go forward, the question is, how do we get out of this? Well, you get out of this by printing a model. And once you print a model and have your diagnostic design, now you're back to analog because the patients are analog. Patients aren't digital. So we'll make our prep reduction guides, we'll make our provisional matrices, and we're back to the races. Okay? All right, so let's look at section 4. And now we're just going to look at cases. We're going to spend the rest of the day looking at cases. And I want to streamline the treatment planning and restorative process. So we've saved a bunch of time on the planning and on the data collection. Now let's look at cases and talk about, from simpler to more complex, how we save time and increase predictability and efficiency and ultimately profitability. This case I actually lost my ass on because it's my daughter, so I had to put a lot of work and got no money, so I can't say this was profitable. But it's a case that I thought about for basically since her teeth erupted, because she had, pretty girl, but she had small teeth, and this was her at about 14, gummy smile. She had delayed active and delayed passive eruption, meaning that her teeth did not erupt completely out of the bone. So if you try to sound a bone, you can't even feel the CEJ. And then the tissues piled on top of that. So we were sent her through ortho, got the incisal edges where we wanted them. And then the plan was to always work with Dr. Konikoff, who is a brilliant periodontist in our area, and do some crown lengthening, which he did. And he did that when she was about 17 or 18. And I have the videos out there. I'm not going to show it here because it's kind of long. But when he reflected it, it was about 3 millimeters to the bone, or to the CEJ. And we wanted a little bit higher than that, and then he had to bring the bone up. So got the bone where it should be, got the tissues, created about a 3 millimeter dimension. And then as she got a little bit older, the tissues, her teeth are really flat, so the tissues started to creep down a little bit again. Bone was the same, but it was like about 4.5 millimeters. So he went back in when she was about 24-ish and tweaked it, and now she's 31 and it's tweaked, it's come down a little bit. So he's retired now, but he came over and consulted, and he felt like that if I brought the tissues up, because we're now about 5 millimeters from bone, that if I brought the tissues up about 2, we had my periodontist in the office take her frenum, and we just put a no prep veneer on that had a little bit more convexity, would help hold the tissues there. And she wanted to do that. She's trying to be the go-to aesthetic person in our practice and in our community. And anyway, she wanted to fix things up a little bit. So here she is now. A little bit of wear and tear on some laterals, but still some of the mamelons exist there in the centrals, which she likes and wants to see reflective in her final restorations. So here's the big ones, right? Rest, showing plenty of tooth structure at rest, tip down smile, central incisors are really where they need to be. And if I do no prep, they're going to be too far out. So we at least are going to have to disc those in a little bit. Where the laterals, canines, and bis, we can probably build out a little bit. So this picture is huge for us to determine where we're going to do some minimal prepping. Her E is probably more of a big smile, but you can see a little bit gummy. She wants to change that. And then the profile. Profile. See, we're tweaking her Invisalign, so we're getting, at this point, getting the lower incisors sorted out a little bit more. We got to intrude 26 or 25 a little bit and get it in better alignment. But canines are in class 1. I equilibrated her many years ago, and it's just a teeny bit off, so I'm going to have to do a little tweaking on her, her bite adjustment, but not too much. So she's about 8.3 by 8.6. And remember, we want at least 10.5, right? If she's 8.6 wide, we want that 80% with the length ratio. And so figuring out maybe adding just a teeny bit of length in this area, but coming up primarily, that's going to get us 10.5, 8.6, give us 81%, which would be pretty ideal for her. So thinking about it, something like this, making the laterals and broadening her smile a little bit. And then as we move teeth around, getting those lower incisors dialed in as well. So we'll mount the models. And here again, we're on the articulator. Get that on there, and then I'm going to go ahead and get the photograph. We used her full face, and that's what we want to see. Scans attached to her photograph. The top of that articulator is level with her eyes. Now everything's hanging as it solves that problem that you were talking about. Now we're just looking at first point of contact. You've seen this already because this is the one that we looked at, but I'm just going to close and make sure I see where that first point of contact is in the bis. And then we can talk about the different ways we're going to equilibrate, but that's essentially first point. And what we decided to do in this case, because Caitlin was kind of helping along with the plan, is we went ahead and didn't equilibrate digitally, but we did her diagnostic design. And this is Matt Roberts. I love his contours. And then we took this to the AD2 mounts. And this was the case I showed you us mounting and equilibrating. All right, so with the design in place in the anteriors, we just crashed. Could you come up and see where was the, let's see if it pops back up.
Where'd you have your file?
It's somewhere where the D's, right there. There we go. That's weird.
Yeah.
All right, so we're back to, you've seen me do the equilibration part.
Oh, there you go.
And so this is what the analog, I showed you this already. I also want to show you if we do it digitally, we can close this down to the first point of contact in the front, or the contact in the front, and then anything that's sticking through, we can just adjust. And so you can see there's not tremendous amount of equilibration. I try to leave a little bit where your central fossa, marginal ridge, and cusped tip would be. But what you're looking at here is we're actually looking through the lower scan at the upper jaw. So I'm actually equilibrating the upper jaw through the lower. So this takes a little bit getting used to, but it's very, very efficient just to making sure. And to your point about positives, if you ever have you can have a model in here that's a ghost of that's like untouched. You can compare where you were to where you after adjusted and know precisely how much you've removed. Which again, in the analog world, once you've adjusted it, it's kind of gone. You don't really know how much you've taken away. But anyway, so that's trial equilibration digitally. Now we're going to take her design and just do a mock-up before we do anything. And this is just Luxa Temp right over her teeth. It covers her teeth and her gums. So she looks at that. I'm like, what do you think? And she's like, let's do it. So now we're going to go ahead and dive in. So let's take you through this case. So the first thing I do in a case like this is I'm going to equilibrate. So I'll lay her back. I've already looked at where we need to adjust. So any inclines that are interfering to center correlation, they're usually on the sides of stamp cusps. And so I'm going to take away those inclines until my cusp tips are landing on flat surfaces and marginal ridges. I typically use a finishing diamond for this. You can see that slope right there. I'm going to leave where the mark is on the cusp tip, but take away the incline. All right? And as you do, it continues to close further. It's going to mark again. Muscles are starting to relax. And we'll follow that along. I also like using these carbide finishing burrs as we get closer, because then we're polishing and smoothing as we're dialing this in. And we want to get to a point where, oops, I think I had one more that I wanted to, yeah, so now we start looking in here. You can start to see our marks where they're appropriately be a little bit bright, but you can see them. Cusp tips, marginal ridges, central fossas. And then the last little bit will be just excursions. And keep in mind, if you get disclusion on her natural dentition and then you do veneers and add a little bit of link, they're going to disclude even faster, even better. Not when I'm equilibrating, because it's really light touch, and I'm not leaning into it, and it blasts away all the marks. So just you're not really heating the tooth up. Just light. Don't put pressure. Very light. Finishing burrs. Yeah. All right. So lines in front, dots in back. Then we'll go in and do the gingivectomy. So now you can see I'm about 5 millimeters from bone. I'm sounding to bone here. Yes, she's numb. Okay. I always mention that because I was teaching this principle years ago at Dawson and bone sounding, and there was this young guy asking a million questions. And I gave him my email, and he had a question for me about every day. And one day I get back to home, and he's like, dude. He called me dude all the time. He's like, dude, that bone sounding thing, I'm really hurting my patients. And I'm like, dude, anesthesia. You know. All right, so we're going to do sound to bone, and now we're going to do the laser. And so I just eyeball this. I'm just eyeballing it. I'm bringing it up about 1.5 millimeters. And then what I do is I make a suck down on my design where we've done the gingivectomy and the wax up. So I'll be able to make sure that my heights are where we're visualizing. So this is a water lase. It's a great laser. It will do hard tissue as well if we need to, but we don't need to in this case because she's 5 millimeters, so I'm bringing her up about 1.5 millimeters. And of course, she's talking the entire time I'm doing this. So we're starting to get within 3. What are you doing now? What are you doing now? All right, so it's starting to look good. Teeth, and again, all in enamel, right? That's what you like to see. So this was normal active eruption because the bone's been brought up, but the tissue sort of slid down. So that's looking good. So now we'll pack cord, and I'm basically doing a very minimal prep. I'm not going to have a margin on this. So when I do these no prep or minimal prep cases, I still like to pack tissue. The reason I like to pack tissue is I'll pack it, and I want my veneer to go to where the cord is. So it gives them an extent, because if you don't have a finish line, they don't know where to stop. And so this way I can kind of control that. So I started to do it this way. It's really giving us nice results. And then I don't really have it in here, but the first thing I did was just leaned. I brought her incisal third back about 3/4 of a millimeter. And then I'm just really leveling everything at the top because we want a definitive lingual incisal margin where the veneer fits. Yes?
Why do you not do a finish line?
I'm just finding that with the no prep situation, if I don't touch the teeth, I'm going to stay 100% in enamel. And when you get down that far, when you start putting a margin there, it really can start to get to the dentin. So if I can maintain maximum enamel, I think that's a really good thing.
It's just a feather edge.
Yeah. And what the lab struggles with is where to go. So having the cord in there, facilitates that. I have other guys that will like just put a line, just a mark on the tooth, and I think that works. I do think the other thing you should do on these cases is just bring in the line angles just a little bit, otherwise the veneers start to get fat. So bring that in a little bit, and then we're still going to have our prep production guides that compares where we're going, just to make sure that we've got room and we've got plenty with where we're going. The main thing was making sure I had the room in the incisal third here. All right, so then we're going to scan. So we'll do our master scan at this point, nice and dry, leaving the cord in this case. And then we'll do the temps. So shrink wrap. Now, one of the things I've started to do, I did a case that I put in Wednesday. It was a 10-unit case like this, and it was so little prep, it was really almost a no prep situation like this. And what we did, we brought her in, we put on the provisional at the beginning of the appointment, dialed everything in, and she liked it, took our pictures of it, took our scans of it, and then I took it off. And then we did the pack the cord and prepped and did the things. And then I didn't put temporaries on. And dude, that was amazing, because these thin veneers, they have problems with the temps, and they came back. The tissues are pristine. You know how veneer tissues after temp veneers can be kind of tough. So that's another reason the no prep is kind of nice. Now, if you've changed things a lot or if you prepped, you can't do that. But in this case with Caitlin, I was doing a provisional, and a lot of it was, I hadn't thought about that yet. But the other thing was, I just wanted to really be sure that she lived with it a little bit to make sure she liked the length and the contours and everything. So any bonding resin after the etch, we'll put the Luxatemp on. I let this sit 5 minutes. And we'll pull it off. Looks pretty good. And when we start, she's still talking. When we're finishing these things, we don't want to nick it up. And I find that the ET finishing burrs from Brasseler, they have a 6, a 12, and a 30 bladed finishing burr. If you use a brand new 30 bladed finishing burr, you can run this along the margins, and it'll just melt the stuff away. It doesn't nick up the tooth. I would not use the 6 or 12 bladed one, because that could dig in there a little bit. But you do want to clean this up. We're going to give her a water pick. We want to be able to sure she can water pick in between and all that. So first step is just going along, getting all your margins clean. We use the football-shaped one on the lingual. And then we'll come in with some, I'm not that fast, but just sped things up a little bit. And then just some polishers. So you don't have to go crazy with this because we do use a glaze, and I'll tell you about that, but just making sure you're getting any little rough areas. These are from Ivoclar, and they have sort of a pre-polish and a post-polish. Works great for ceramics as well. And then the last little bit will be, this is a aluminum oxide impregnated finisher, almost like we call it the Christmas tree. Looks like a little Christmas tree. And then the last step is this OptiBond OptiGlaze, yeah, that you can just light cure. I've really found I used to really air thin it, and I've started to leave it a little bit thicker and cure it, and it stays on better. So we'll cure that, and then once the temps are on, we'll have a little bit of adjustment, little equilibration, make sure everything's good. But in the end, what I want to see is I want to see everything coming together. I want to see smooth protrusion, smooth canine guidance and crossover. And if all that earmarks is there, then scan that, photograph that, and we're in business. So what I want to turn next is, now that we have this digital data, so imagine sending this to the lab, and you've got the scan of the prep, you've got the scan of the temps, you've got photographs. Now in the analog world, we were big believers in using an impression of the provisional, and we would cross-mount the provisional model with the die model, which meant you put the provisional model on the articulator, you could make a putty matrix of the incisal edge, you could make a custom guide table, and that would drive the length and lingual contour of your permanence. But if your temporaries model was mounted a little differently than your die model, you can get some inaccuracies with that. So these provisionals are going to be key, and what we can do in the digital world is the lab can take my prep scan, they can take my temp scan, and they can superimpose them on top of one another. So with a few clicks of a button. So it really makes it easier for them to go. So there's Walgo, there's, as she post-surgery with a little bit of creep and where she is in the temps now. She's always going to show a little bit of tissue. I keep telling her what's going to maybe amazing when she's like 50. Her smile's going to be perfect because, things kind of, little gravity. I love that picture. But pretty good. So now I'm going to send it to Aaron Johnson, who's one of my new best buddies. I started to use him. I did the Pankey Scholar program this last year, which is about an 18-month thing. And one of the other guys I was doing it with was working with Aaron, and I just was seeing this incredible work. So I reached out to him, and he's doing all my minimal prep cases now, or my no prep cases. And what I love about it is that he totally gets these digital workflows. And one of the problems with no prep scenarios for me is when we were doing like feldspathic work, I'd work so hard on the temporaries, but then they would start hand stacking the feldspathic, and it a lot of times wouldn't resemble that much what I've worked out. And so I just found a little inconsistency. What Aaron's going to do is he's going to take the digital design, my digital design, and he's going to work inside a 3Shape with an Emax milling product, and he'll mill it and thin it way back down and keep it within the confines of, and he mills them down to he's bringing these down to 2/10 at the neck, and the whole veneer is probably 4/10 at the incisal10. But anyway, so let's talk about it. And so our first conversation with him was that potentially 10, and maybe the distal of 9 was a little bit short. So he's like analyzing the heck out of my photographs and recommending things that we could make little tweaks on. And so we had a team viewer meeting, and again, this is the other thing about the digital world, is when he has a team viewer meeting, I dial into his computer and I'm staring at the virtual articulator. So we're sitting, he's in Idaho, and we're sitting like we're working right next to each other. So this is some of the little notes that he made, and then he can take my provisional, and then that's his design over there. We're keeping everything in alignment. And again, looking at my provisional up top, you can see 10 is shorter than 7. And so he's correcting some of those things and bringing a little bit of more length to 7, a little bit more length to the distal of 9. I mean, this is subtle, crazy, subtle stuff that in the analog world, we would have a hard time having these conversations. We can talk occlusion. Again, it's a perfect class 1. The canine's landing right where we want it. And then this is what he does. So he can export this, and this is essentially where the sprue is, the blue state. Here they are being milled. And then he's got to grind that back. So that's got to be stressful as you thin those things out. Cuts back the facial a little bit and does some layering. And then these are just floating in water. So you can see how thin these are. So it's impressive in a completely digital environment. We used to not see that unless it was like hand stacked. So there they are, us on the model, and then he's got natural dyes. This projector's a little, let's just look at this. It looks really bright over here, but straight out a little better. And then they were bonded. So there they are in the mouth. And again, I love, remember the little mamelons, all those little edges that he put back in there, that characterization. Better symmetry. It's interesting, I didn't really change the width of the teeth, but they look thinner because the rest of the teeth got a little bigger, so there's a little bit of proportion things going on here. And then you can see here where we pulled the incisal third in, but built out the laterals and canines to give her better fit with her lip. That's probably why it looks narrower, because we pulled them back a little bit. They're going to get a little thinner. And then good occlusion. So we got our lines on the canines and central stops in the back. And good guidance, nice and smooth, just like we saw in the articulator. That's just canine guidance, and then looking at crossover. Oop. Nice and smooth. Protrusive, and then making sure she can go out. No rubbing of back teeth. Smoothly onto the central, missing the lateral. So here she is before, provisionals, post-op. Again, through this process, we're trying to get progressively, I hate to use the word optimum, but that's what we're trying to do. And that's a pretty good post-op, but I was trying to find the best one, like the most natural one, and our favorite place to go is Smith Mountain Lake. We got this little toy this summer. It's so fun, the e-foil. And so trying to find her, first thing was, surfing. Yeah, that's pretty good. But then I found that if Fireball was involved, it really, she really got a good grin out of her. But anyway, that's Caitlin's case. All right, so let's talk about digital orthotics. We had a question online about splints. And this is another area in our practice where we just we save massive amounts of time and money, because again, in the splint world, having the ability to do some of these things are important. So starting with a good scan, we want to make sure we have enough extension to do what we need to do. So if you're going to be making a mandibular one, having those little areas of data points that you're missing may prevent you from being able to do like a tanner, where the tanner or the Pankey appliance goes deep. So just really analyze what you're doing and make sure you have all the data sets. As we think about TMJ patients, this goes beyond this course, but I do want to just remind you that if you're dealing with a TMJ patient and the disc is forward or the condyles are breaking down, centric relation by definition no longer exists. So Dawson wrote a paper in JPD in the 70s called Adapted Centric Posture, An adapted centric posture is the position and condition of the joint once it's stabilized, either through splint therapy or surgery, where you can load the joint again in a most seated position without tension or tenderness. And I would add to that, and I'll also have evidence on a CBCT that it is recorticated and stable. It'll never be as stable as a perfect joint, but it is a treatment position we're shooting for. Okay, so typically in a TMJ practice or TMJ patient in my practice, it might take us 4 to 6 months to get them stable in an orthotic. And then I like to see a good 3 months of stability with no change in the appliance before we consider doing anything permanently, equilibration, ortho, restorative, or anything like that. But we're still going to want stops on the appliance. We're still going to want to have anterior guidance and posterior disclusion. We still want to have crossover. And so we got to remember what we're trying to do with splint therapy is we're trying to create an environment where we lower muscle activity and allow the joints to heal. Okay. So Splint Studio in 3 shapes is a great part of the software, and I'm not going to take you through all of this, but we do have the ability to go in there and choose what kind of appliance, any appliance that we make, whether it's a deprogrammer or the little deprogrammer that I make. Sometimes it just fits in the roof of the mouth. A maxillary Michigan type splint or a lower Pankey splint, we can make all of them on there. Software doesn't really care. But we're going to, again, mount the models. It's a little different, but we're going to create that vertical that we want the splint to be the space that we want to occupy. And then what's pretty cool about it is then we just going to block out areas that we might want to block out. I will tell you, in the way we make appliances now, I very rarely block out anything. Why? Because the materials we're using, while very hard, are also a little bit thermoplastic. So we can heat them and deliver them where they kind of, I'll show you, but it's really, really slick. Because these type of appliances, we used to always have to reline them, and we don't have to reline them anymore. Saves a lot of time. But you see us marking the outlines of the splint, and then we can choose in the posterior that we just want that material to just touch the occlusal surfaces. It's going to be anatomic, it's just going to be flat. And the anterior, we actually want to have a ramp. So we're going to have some ability to create some disclusion. So we'll go through that design, and let's see, here we go. We'll go through that design and get the centric stops where we want them. There's sometimes a little issues with protrusion, so sometimes we have to protrude and then close. But we have the capacity to work out all the lines and dots. And then we can nest it and splint it, or print it. This is how we started. This was an absolute nightmare because we thought we needed all of these like structures, but that leaves you such a tremendous area to clean up. So if you're doing some printing of orthotics, don't do it this way. What's much better is you can just arrange it on the build platform like this, where the only thing you have are the little supports right distal to the splint. And so visualize that when this gets printed, the first layer is here, and then it just builds this way and actually connects in the middle, right? But when you take this off, there's like nothing to clean up. You knock off the back little areas, and everything is polished beautifully. We can do multiple splints at a time, so Charity will typically wait till we have 3, 4, 5 of them, and usually print them, unless we're in a rush. And we did the math on this about how much this costs. So it's about $450 for a bottle of the Sprint resin. And we get, if you do it, about 10.2 milliliters. It's a 1,000 millimeter bottle. And we get about 10.2 milliliters to make one splint. So that's about 98 splints in a bottle. If you figure in 20% waste, which there isn't, but it's like 78 splints, it's about $5 a splint. So I mean, when you start thinking about that, I was spending $220 for high-end splints at Great Lakes. It does not take long to pay for this when you're you're doing it. But that's what we want to see, right? We see our marks, want to see the lines. The other option with this nesting option is to just, rather than having like a support, you can actually grow that area of the appliance a little bit, and then similarly just line it up on the build platform. We found that just using the supports is the easiest way to do it, okay? Because the AI will do a lot of this for you. Now this is the material we're recommending. You still using the same stuff? Yeah. So Key Splint Soft, it's a horrible name because it makes you think it's going to be like the rubber night guard you get at the 5 and dime store. This is a hard material, but they have a Key Splint Hard. And you'd think the Key Splint Hard would be better, but it's very brittle. It breaks. So we find that if somebody's really clenching on it, they crack it. This has a little more modulus of elasticity, I guess. But printed, it's hard. It's a hard material. So I love it. It is rigid when it's cured properly. Make sure if you ask for this material, it's being printed in an approved printer and that it's cured properly. The thermoplastic nature of this allows for rapid delivery, optimum retention without reline, allows for easy adjusting. If you're using an Asiga, they have these ultra gloss trays that make them crystal clear, which I think is pretty nice. This is Charity. She likes taking pictures of her splints outside in the sunlight, which cracks me up. But our assistant does a great job with these things. But the main thing is when they come out, you do the bath that you are, you need to put this in 99% isopropyl alcohol. And when you're doing this with models, there's often something you put it in that spins for 20 minutes, then you put it to the next one. Don't put these in there because it'll just muck them up. So what we do instead is we just have a bottle, spray bottle. We take it out. Charity will blow air on it. She has mask and gloves on, and then she sprays it, hits it with air, sprays it, hits it with air. Usually within 5 or 6 minutes, you've got everything off of it, okay? So this just keeps it clean. If you're putting it in the bath with everything else, all that resin's going to stick to it and make it look nasty. Then it's going to be cured. This is the Oto Flash curing unit, a little bit more expensive, but it does cure in the presence of nitrogen. And the benefit of nitrogen is it totally eliminates the oxygen inhibited layer. Not as important with this, but starts to become more important if you print provisionals and restorations and things like that. So just keep in mind, this is changing rapidly though. This was the hottest one on the market probably 18 months ago, and there's 3 more now that are like it. So cure properly. If you find that you get one of these back and it just feels soft or something, it's just not printed. It's probably not being cured, or it's not an approved printer. So this is what thing looks like. Drops in there, and then if you've got this clicked up, it'll take a second, but it pulls all the oxygen out of the chamber by putting nitrogen in there, and then it rolls. All right, so this is the key. This material will finish up. If you've got a lathe, you can put it on there. We'll hit that up last with like flour pumice. But we'll keep it, we won't really finish it completely till we've adjusted it. But at delivery, what I want you to see is if I tried to take this appliance and put it in her mouth, because I didn't block anything out, it would not seat. Like you wouldn't be able to get it in. So what we do is we take one of our green Elgiment bowls, because we have to have something to do with those, right? And we put hot water in it. And what I want you to see is when we drop it in hot water, like hot water for 10 seconds, look at how this thing becomes flexible. Watch me squeeze it. So this thing now is like a little flexible. And what I can do is I can go to the mouth and it seats. And I seat it just like I'm doing a reline. So I'll put in one side and I'll hold one side and just lift it up, have her bite, lift it up, have her bite, lift it up, have her bite, and let it cool like that. And now you have an appliance that snaps in but is completely passive. And so again, this saves so much time because this used to be relining. And so a couple tips on adjusting these things. First thing, go ahead and sit them. TMJ patients, don't lean them all the way back, because the jaw can fall back, and sometimes the jaw needs to be a little bit more forward if they're sore. So adjust in a postural position. Make everything hit evenly. Once you're there, we're going to check disclusion, and we want to make sure that they can, like my ramp's kind of steep right now, so if it's too steep, they won't be able to smoothly go. Like I want it to be anatomic so she can't rub on back teeth. I want those lines out there. So what I'm doing is shallowing things a little bit. I wanted to get her off the lateral and crossover, and just make sure everything's comfortable. Yeah, so I'm just getting her off that lateral now, finding that line until we're there. And then it's just a matter of finishing and polishing. And I want to snap in, watch her close, watch her slide around smoothly. And again, now in my practice, I mean, my assistants do 90% of this appointment. I kind of come in at the end and might tweak a little bit, and then we just want to make sure she can get it out and watch the retention. That's what we want, right? Snap it in so it's not bouncing around. All right, let's talk a little bit about implants as part of a rehabilitation where it's partially edentulous. All right, and sort of start, again, thinking about all these different modalities that we've got, but again, layering in some of the other things we can do by staying in a digital environment. So she's 30 years old. She was referred by Dr. Roy, who's the orthodontist. He's part of my interdisciplinary team. Mild localized gingivitis, gets spot bleeding, normal range of motion, normal load tests, history of joint sounds, sore muscles, temporal headaches. Again, joints were fine, but definitely has some occlusal issues, minimal wear. Lower teeth are shifting and migrating and no mobility, wants to improve her smile. This is one of those patients that when we first had the consult, you know, we planned on getting her records, and the little new patient interview went on for about an hour and a half. She just needed to tell her story. And I don't think I heard all of it. I think it was worse than what she told, but she went through braces as a kid. Something was happening at home. I think it was abuse. But she ended up running away from home at 15 when she had braces on, went out to California, did some bad stuff out there, and somewhere along the way took her braces off herself, kind of mid-treatment, and then was left with some gaps in the front. And I think the teeth were, we know the teeth were pegged. We didn't know it at the time. But somewhere along the way, she had veneers placed on the laterals. But you'll see in a second, they're pretty big, you know, compared to the centrals. And as part of her ortho, she'd had bicuspids removed. So she's got weird spacing all over the place. So Carl sent her to me because he wasn't sure what to do. He's like, this is one of those things, I think you need to look at it. And I ended up bringing her to my interdisciplinary meeting so we could all talk about it. So first thing we look at her, her stop bang. She's definitely, you know, heavy, and she told me that she was looking at this as something in her life that she wanted to get her life back. She wanted to lose weight. She wanted her smile back, so she was going to make a big change. And I really said she was willing to do just about anything. She has a good job in our area now, but certainly has a intermediate risk for OSA. And we recommended a sleep study, and her AHI was 9. So she had a mild sleep, not huge, but for somebody that's in her early 30s, you know, this potentially is going to go the wrong way. And what she wanted to do was to control it with weight loss and with maybe some of the things that we're doing. So I said, well, let's certainly give that a try. This is her probings. Again, some bleeding on probings, but nothing crazy. Got 1, 5, 4s, and 2s, so she's going to need some scaling and root planing. And then you can see the problem. So in this picture, you can see the size of those crowns. And then you can see that space distal to the canine that's challenging. It's like, how are we going to help her? But biologically, pretty good, you know, not crazy. One of the things we do for our virtual articulator now is if we take the CBCT, and we need to because we're looking at facial bone and potentially implants if we move teeth, is we can pull the condylar path off of this. So this is a 42-degree slope. This is 36. So if you want to program your articulators for the path, this is a great, simple way to do it. You don't have to take a protrusive bite. And then just looking at it, pretty healthy joints. So just looking at her pictures, I brought her to my interdisciplinary meeting, and Carl had seen her, I'd seen her, wanted Albert periodontist to see her and Majuri to see her. We also had another orthodontist and periodontist there. They're the young guys that are starting to take over the group. And we're just scratching our head. Like, pretty big Bolton discrepancy of what's going on here. So I also mounted the models. Not terrible. CR and MI is not that far off. But one of the things I hated was we also have a pretty serious problem with where the lower canine is. It's pretty, when we close all the way, it's very class 3. So that's a problem. Like, how are we going to get function where we want it? So this was the discussion. We're sitting there, and I said to Carl, I said, really love it if you could open up the space. Like, if you could get space back for me to put an implant in those buys. Like, can we do a Sarpy and expand? Like, I just would love to have the buys back, and I'm whining that he can't get the canines into class 1. And so the periodontist, who's a genius, basically said, what's under those crowns? And I go, I don't know. And he goes, call her. So I ran. We're at Carl's office, so he had her cell, so I called her. I said, do you remember what your teeth look like under those crowns? And she said, yeah, they called them poles. I go, pegs? And she goes, yeah, pegs. I said, they're pegs. I said, oh, they're small. So I come back, and he goes, Jhon, what if you went in there and you took about 1 millimeter or so off of each side and opened that space up, then could potentially Carl distalize the molars and expand a little bit and create space. So kind of elegantly, simply, and he goes, well, I don't know. He said, I think I could. So he's looking at the scans, and so we start talking around. It's funny because Carl always hated Invisalign, mainly because we could do it, I think. But what he said is, in this case, I think I'll use Invisalign because the risk is that it's more of a closed system. You put a wire on, teeth can move quickly through bone, but Invisalign, it's going to move from here to here to here, and he can take a couple steps or CTs along the way to make sure he's staying in bone. So that's essentially what we did. We were going to shoot that, sat down with her. She was open to try. And then, of course, if this is successful, then we'll put implants in the first buys, and then I'll restore the anterior teeth. And an equilibrator would be an 8-unit case. So kind of visualizing something like this with the space for another tooth in there. Got a little bit of reshaping and bonding to do on the bottom, but nothing crazy. So 4 quads, scaling and replaning, and incisal resonance 23 through 26, perio recare. He also did do a splint first, just because of the muscle activity, and they used what they call a MAGO. I think it's maxillary anterior guidance orthotic. It's from the face people, and OBI people do it. It's the same principles that we use. He's going to go ahead and do the ortho, and then I'll do the restorative planning and the implant planning with Dr. Niver. And this is really the key, is post-ortho, I'm going to get involved, remount the case, and do all my restorative planning so that I can do my surgical planning with knowing where the teeth are going to be. I'll equilibrate while healing, and then we'll go ahead and do 6 through 11. We've got 4 veneers, 2 crowns, and then implant crowns 5 through 12. Then we'll deliver 5 through 12 and get her back over to Carl to deliver on upper, the guard and the retainer. All right, so this is essentially where we are. He did the splint therapy prior to that. And you get a good view of where everything is. So this is what's kind of funny. So I don't really check hygiene in my practice anymore. My daughter's there, and we have another doc that's just starting. And I kind of am in there a couple days a week and do my kind of the specialty side of things. And Caitlin was saying, so she was coming in for hygiene, and the ortho was going on. And I think he ended up doing like 26 aligners and then a refinement. So it was a good bit of time. But every time she would come in, she's like, Dad, Andrea's looking really, really good. And so when I finally saw her for her post records, she had lost something like 80 pounds or something. You know, she's really done what she said she was going to do. I think there may have been a little bit of Zepbound or something involved with this as well, but she's seen her going to the same gym Caitlin does, and she's really transformed herself. But when we look at where we are, we've got the space, which is awesome. And what I really like is look where the canines are. Class 1. It's slightly open, but I still got an equilibrator, so when I equilibrate, it'll drop in. And so now I can go ahead and do my occlusal analysis and put this back on the articulator and see how things are lining up. I can certainly overlay. This is where she started. Actually closing it down now, looking where that first point of contact is going to be. So hitting a little heavy on the right, but this looks very equilibratable to me. And so now I'm going to take you through. So we're getting ready to do the implant surgery, but let me show you in fast track how we do the design. So this is what the order form is. This is the stuff Cornell does for me. And so we'll fill out the order form. He'll bring in, we'll get the case mounted. We have to clean the models, which kind of fills all the little holes. He does that for me. Remove any little attachments. He'll pick the teeth on where I'm going to work. He does that for me, and he usually gets the case about right here. And then I pick it up. So at this point, I'm going to get things aligned. I've got the crowns or where they're going to go on the buys. I'm going to leave the lingual of the upper incisors there. I mean, I'm going to take the crown off, but the lingual contours are fine. Now I'm doing the trowel equilibration on the natural teeth. And then we'll bring the restorations in, and I've got doing a little occlusal work on where my implant crowns are going to be. And this is really what I want to do. I want to see where that is before we do any planning for the implant. So once I have that done, I can export that as an STL. Now I'm opening my real guide, and I'm bringing in the STL, and I'm laying it on top of the CBCT. So I know exactly where that crown is going to be. So when I place my implant, I can see exactly where I want the exit hole. I can plan for the sleeve size and the angulation of that. And you know, there's not a ton of space here, so I want the periodontist to be able to thread that needle. And I can even change the angulation of that sleeve. Then we're outlining just like we did with the splint and where the surgical guide's going to be made. I recommend if you do these things, definitely put little holes in them so you can see through it. This is important to make sure your guide is seated. If you're doing enough of these, put the name on the patient on it so you're not confused from one over the other. And then it'll generate the reports for the guided surgery. This is going to be a Zimmer case. And that's what the guide's going to look like. So Niver's going to go ahead and pop those in for me, and he basically puts those in. She's still wearing her Essex with the tooth in there, and we just let it integrate. But I now have the model, like I can use that same model when she's ready, right? So when she's ready to do her thing, I bring her in. I'm going to do screw retained temporaries on the buys, shape tissue a little bit. I've got some veneers and 2 crowns on the laterals, and so here she's starting to look pretty good. There's rest, tip down smile, E. It's interesting, she doesn't show a whole lot at rest, but her E is pretty normal. And what that tells you is she has some hypermobility to her lip. Again, cool bit now, so canines are socking into a nice class 1. So I've got good guidance, and so I'm going to scan the temps like I've shown you. We get the scan of for the master model. They'll superimpose one over the other, and that will drive the final. So pre-op, post-ortho, and then provisionals. There's our master scan. Oop, there's our scan. You can see the scan bodies on the back there. And then our temps. Our finals. So now we're in zirconia, or in the Emax. Now you can tell by her shade. Does she live? She's flat nab on the oceanfront, right? I mean, she's like swimming in the Atlantic. She's tear teeth. That's what she wanted. So I wasn't going to argue with her. I don't always love this, but I've learned that when I talk people out of what they want, sometimes it bites you. So I know you got some white teeth running around in the DC. I see it. There's the guidance and the stops. And a nice case. Her hair changes colors every time she comes in. But you look at her. Do you think she feels different about herself? You think teeth matter? Yeah. It's awesome we can be involved with things like this. Look at her face, and that's the other thing, is look at the tension and look at what the expansion did to also bring her lip support back. And what's really cool is we remember where she was and where she ended up, HF4. So that's a pretty good change without any. All right. Looking at the whole transformation, pre-op, post-ortho, provisionals, to the finals. Her hair gets redder over time, too. The goal, I hate to use the word optimum, but that's what we're trying to do, right? Progressively towards the goals as we move along. So these type of cases, we can look at what we charge and all that. I build in time, like when I'm thinking about these cases and you're doing a lot of interdisciplinary conversations, however you're going to charge, I try to be in that $1,000 to $1,500 an hour on cases like this. And so don't forget to build in that time, because there's a lot of discussion. There's a lot of conversations that goes in with those type of cases. Labs, the thing when you're working with a lab guy that really knows what you want to do, I've got condylar path in there, I've got what I'm going to do, but he knows what I expect him to do with the scans that I send him. He knows how to data stack. If you're working for a lab for the first time, there may be some more hand-holding that needs to go on with that. But those principles are what's going to guide cases like this. All right, let's spend the next little bit and talk about vertical, and then we'll wind up. And I'm going to show you, just introduce you the concepts. I'm going to show you the one case, and then we'll wind up. So I'm going to jump forward a little bit. But the first thing that we have to understand about vertical is there is some debate about what vertical dimension is, and can we alter it? Can we mess with it? Dawson's chapter on vertical dimension in either of these books, I think, are the best chapters ever written. So if you want information, buy either the older red book, this is the newer one, and the chapter on vertical is amazing. But I'll tell you basically what it says, is that he believes that vertical dimension is created by is basically measured by the distance between the nose and the chin when the teeth are in maximum cuspation. That's the patient's vertical dimension. And what he also believes is this vertical dimension is created by the repetitive contracted length of muscle. So the 3,000 times a day that we swallow and our teeth lightly touch, the muscle was there before the teeth. So that repetitive contracted length of swallowing is the maxillomandibular relationship that teeth erupt into until you get an equal and opposite force. Right? So that's pretty logical. So teeth weren't there as we were growing. There was a space. There was this repetitive contracted length of muscle, and teeth erupt until they meet an equal and opposite force, and that's what sets up the vertical dimension of occlusion that is familiar to us. What may be shocking to some of you is he also said a couple things that beyond this, which we'll get to in a minute, but muscles are there before teeth, so the muscles determine this maxillomandibular relationship. Teeth erupts until something stops them, and then another thing he says is when teeth and muscle war, the muscle will never move, never lose. So for instance, if you put a posterior bite raising appliance in somebody's mouth, like a Gelb type TMJ splint, ever seen a patient like that? If they wear it for about a year, when the patient comes back in, you can take the splint out and you have all the posterior teeth intruded. Front teeth are touching. What happened? Well, that repetitive contracted link, that muscle just pushed those teeth down, right? So we believe that this repetitive contracted length is what establishes that, and if we open vertical dimension, it doesn't really hurt anything, but they will go back, even if we open it all the way around, which we do a lot. We have to sometimes. But they will go back to their vertical dimension. They often, if we do good occlusion, they won't even know what's happening. And the other way to look at this is that if you have a patient that wears their teeth out, that even in rapid abrasive wear, we don't think people actually lose vertical. Because what happens is as they're wearing their teeth out, we have an elongation of the alveolar process. So we have to be careful of that because we often think when we're adding to tooth structure, when teeth have worn out, that we are in fact opening the vertical dimension or we're restoring the vertical dimension. We're actually opening vertical dimension a lot of times. It's not a problem. We have to know for a short period of time, 6 months, we may be introducing a little instability where we've got to keep a little bit more close eye on the occlusion. That's why many times when we're opening vertical, we might want to keep them in provisionals for a while longer, because I'd rather them do something to provisionals than to glass. Now, if we look at this, this is an intriguing way to think about it. If we think about a patient that's unworn, and we look at the bottom of the mandible to the cusp tip of the lower, and from zygoma to the cusp tip of the upper, and then A is from the same position to the CEJ, what we see in the worn dentition situation is the B line is the same. So the distance from the bony points to the cusp tip is the same, but the A line is longer. So visualize as teeth wear, teeth aren't erupting out of the socket, but we see an elongation of the alveolus. That makes sense, doesn't it? Because when we show you worn dentition cases, if we're trying to add length, if they've worn their teeth out, if none of this is happening, then we should be able to add all the length to the incisal edge. But that's not what we do. We often have to add a little bit to the edge, but what are we doing? Crown lengthening a lot, right? Because of the passive eruption that occurs along the way. So when we open the VDO, we will often create some instability while the patient physiologically adapts. It generally takes about 6 months of time for this to occur. The patient will be unaware this is happening. There is one important exception to understand, all right? How can we gain space to add to teeth where we don't affect the muscle length? And it's this. If we have a patient who has a pretty significant discrepancy between CR and MI, if we see teeth worn out, I like to see the CR-MI slide. Because what happens is if we put them back in centric relation, the mandible will go back and up and run into a posterior interference, and we get all this space in the front of the mouth. But what I want you to watch is the muscle, because as we go back and up, this muscle length doesn't change much. And so the net effect is this. If we have a big CR-MI slide and we want to add to teeth, then we can often do that and not have any worry about instability from changing. The patients don't need to adapt because we haven't changed muscle length. So I message you this, when you see a big worn case, pray for a big slide. Okay, pray for a big slide. Makes it a little bit easier. Focus on the muscle length. So like in this case that I showed you earlier, if we we're not doing it in this case, but if we were going to add to those teeth and they're worn out, we should be able to add within that space sitting at the first point of contact, and we wouldn't have a problem. Okay? Wouldn't have to worry about any of that instability. When we have a post-interference in CR and we want to open the video, it gives us a space to add to the teeth without affecting the muscle length. All right, let me jump forward a little bit and take you through a good case. And that'll set us up. And we'll look at Melanie, which is another one we're doing kind of segmentally. So 39 years old, she's a dentist. Knows she's all worn out, would like to improve her smile, would like to not prep all her teeth at this point in time, but knows she might have to. Again, good stable joints based on history and CBCT, but more muscular. Again, I purposely picked pretty healthy TMJ patients for this particular lecture. Premolar extraction, a lot of erosion, wear and tear along the way. Definitely had an issue with some of the bulimia and things when she was younger, and that's all been kind of resolved. Had some resin dentistry on the lingual of her canines and on the centrals and laterals. So definitely going to be a full coverage type case because all that dentin had been exposed along the way. But everything looks back, right? I mean, everything looks retroclined. It looks short. She's got a beautiful curve to her lip. Everything looks flat. There's her rest showing nothing. E looks pretty good. Maybe a little bit short. Teeth are back. So visualizing adding some length, bringing them out, which is what we see with the wear. She has that scar up top. She I think she was lacrosse or something, some athlete at UVA. All my kids went to Tech, Virginia Tech. So all that means is when I work on her, there will not be anesthesia. That's pretty much it. Nah, not really. But anyway, so she had a injury to her nose playing lacrosse, and they did the surgery through her mouth. Well, she didn't have a Lafort or anything like that. But, a lot of things going on. Sizal ledges are a little bit short. She's definitely had that compensatory eruption, so tissues aren't in the right place. I'm also worried. She's got short roots, so we're going to have really good control of the occlusion on her. Definitely going to be in a night guard, but she just can't lose a lot of bone around her teeth. Thankfully, probings are good. And we started with just a deprogrammer to see if we could alleviate some headaches. Just did that for about 8 weeks while we were doing perio, getting her healthy and all. And with this in, her muscles calmed right down. No issues, soreness in the joints or any of that. So just taking you through some of the face airway bite stuff. This is what we're basically looking for in a healthy face. If we drop this little line down from the base of the nose, we should see the upper lip about 2 to 5 millimeters ahead, the lower lip about 0 to 3 millimeters ahead. And she's definitely back when you look at her. And we had the conversation, like with the premolar extraction, like if she wanted to have all that restored, she's a candidate for orthodontic surgery if she really wanted to change her face, which she didn't. She was like, if we can fix my teeth, I'd rather not have anything done. And with the terms of her airway, she's scored at relatively low risk at this point in her life. Although she's a risk, we did not do any treatment skeletally. Also class 1 occlusion, so that's good. This is the arch form. You want us from OL groove to OL groove. McNamara says it should be about 36 to 39. She's on the kind of lowish end of that, even with a small maxilla. So teeth were straight, no crowding. There was really no reason to expand or do ortho. And we get to edges. And as I said, we're going to plan this by looking at the lower plane. And with the lower plane, it's almost like everything just needs to be a little bit taller. And this is the wizard. There's the Travis back there. Drew and I created this software a number of years ago, and Travis is back there and has picked up this. It's a great tool for planning, and we were using it a lot back then, and I'm leaning back into it again on creating some things to go along with the digital side of what we do. But these wireframes are really helpful for us to see where we're going incisally and where we need to go gingivally. In our lower incisal plane, we're going to rise up about 1 mil all the way around. So it's like her lower jaw's been on a belt sander or something. Now, I was working with Bayview at the time before I had the software, and this is them sending me a screenshot of their design, canine to canine, and they're showing me where they're visualizing the cuss tips to be in the back. And I like to look at that. On the upper, again, we were taking the pictures out of the wizard, looking at rest and E and some of these things, getting the wireframe, sending that to them, and them doing their design canine to canine. Nothing on the lingual yet. I like that. Seeing where we're going to go. About 1 millimeter of crown lengthening as well as 2 millimeters of incisal length. And now we're going to do the stop, so we're also going to be playing with vertical. And in this case, we're visualizing opening her about the same amount that I'm adding to the incisal length, about 2 millimeters, and then bringing the cingulum down. So our cingulum's getting a little bigger, more room for envelope function, shallower guidance. And so now they're putting the cast together. And so we can see what we're doing anteriorly. Now we have to decide what we're doing in the back. And this is the first time I use toppers. Because if I could bond something to those back teeth, that would allow me to close the vertical and controls the stops and not have to prep all her teeth right now, although she would have to do that, you know, sooner rather than later. So there's the topper design. And once we've got our stops and our vertical worked out, it's a simple matter of figuring out our anterior guidance and disclusion. I didn't have any video on this, but you know, he was doing that in Exocad, so we can see the excursions in that as well. So basically going to be doing all the teeth, making little notes to myself, where I'm doing crowns, where I'm doing veneers, where I'm going to do the toppers. And specifically, face and airway are good, no changes there. And specifically where I'm adding length. This is the notes to the lab, how much I'm opening vertical, about the stoppers, and creating shallow anterior guidance and posterior disclusion. Now back then, we were trying to get the lab bill just as high as we could, so we also did it analog. But it's crazy when you think about, it probably took them an hour maybe to do the design digitally, and this probably took 2 days to do this analog. I mean, you look at that anatomy, absolutely gorgeous. But they both work. They both absolutely work, but one is just definitely going to be a little more efficient. So here is my plan. I actually had the crown lengthening done in advance from Albert, and she's going to come in. We're going to deliver these toppers. We're going to prep and place 5 through 12 and 22 through 27, and we're going to equilibrate and verify tooth position. We're then, after she settles a little bit, impress and deliver 22 through 27, and we'll impress and deliver 5 through 12, scan for the night guard, and deliver the night guard, and just let her go for a while. So let's look at it, because I'm going to take you through the whole case. When we delivered this, what we did, we put the rubber dam on, we air abraded the areas where the toppers are, and where she had some old amalgams, I just took those out. And so we're going to etch and do our bond, and what we're going to do is bond the little onlays on the molar and the bi and get those on and clean them up, and then we'll go in and do this one. So I'm going to jump forward and show you the outer ones are in, and this is how you avoid creating a 3-unit splint or a 4-unit splint that will ruin your day, is do them every other, and then when you're doing this one, get your etch on, do your bond. And then when you deliver this topper, go ahead and put it on, and then use a 2 millimeter tip in your curing light, and you're just going to tack it in the center of the tooth. And that will prevent the resin interproximally from setting up. So if we tack it, then I can get my floss in there, get that all cleaned up, and then cure it the rest of the way. So this is a pretty efficient way to do it. All right? So we'll go around and do all the quadrants, and so now that's where she's at. So with the toppers on, that's the space we've got. So we'll just jump right in and start the veneer prep.
What material is the topper?
So I'll talk about that because at the time we were milling these things out of like a PMMA, and we'll show you. The PMMA will show you what it looks like after 5 years, which is not so good. But now we're printing out of a resin ceramic material called Sculpture, which is much better. Right? It's going to fit better, stronger. Anyway, prep the veneers, then I'm prep the upper crowns. I'm at the point where I'm trying in my temps now. So get those all cleaned up. That's just Luxa temp. We weren't printing yet at that point. And then we'll do a lock-on technique for the lower veneers. And this is the first time everything's coming together. And you got to appreciate this. This is like 2018 maybe. 100% digital environment. This was exciting to us because now we're realizing this is really going to work. She comes back and we start taking pictures of the temps. She's pleased. See the toppers, not perfect, but blending in okay. But there's rest. There's tip down. See how it's following her inner vermilion border so nicely. Now we're on finals now. And what's really impressive to me is look at her profile difference. The support of her lips, because remember we brought the ends, ledges out, open vertical. Look at the tension. Look at her mentalis. It's just more relaxed. And some of that's vertical, but a lot of that is occlusion, like creating an interference-free occlusion. And some beautiful work from Shoji Surrogate, Bayview, and Chesapeake. So the plan was that she would probably start doing the posteriors in about 2000. What happened in 2000? Right, so we started to, so that's how we finished the occlusion. I'm very happy with that. There's the toppers and this process of finishing the case. So she was going to start doing some of these a step at a time, and I lost track of her till about 2003. About 5 years went by, and she came in, and all the anteriors looked good, but some of the posteriors were having troubles. No endo or anything like that. They were just kind of falling apart. So I was worried that when they fall apart that you lose space, like they're going to erupt. So I wanted to get her back and do a design, and we had plenty of room to do what we needed to do, and we're just going to turn her into full coverage now. You can see the contacts in the front. There's the contacts on our design with good disclusion. And so we prepped her for printing some provisionals here. Again, I wasn't sure how tight she was going to be, so I just prepped her and put her in printed provisionals. Wanted to have some time to equilibrate that, and then we converted her. And I ended up building the lower posteriors against the upper printed temps. This is some really nice work from Lee Culp. On the posteriors, good occlusal plane, and then we did the uppers against the lower permanents. So what I would say is the toppers definitely are a good choice. I would use the printed sculpture materials. I would prepare people for maybe 2 to 3 years max. It's probably good. And then I think you are going to be good. I think we pushed the envelope on this one. Different, isn't it? Look at how different her face looks. She didn't lose any weight, just longer. All right, I'm going to jump forward and I'll give you some final thoughts and get you the heck out of here. So I like ending these things on a philosophical note. My stepdad was an amazing man, World War II vet. May have been one of the only vets that was at both Pearl Harbor and D-Day. He enlisted in 39 and happened to be at Pearl in 41. And so he just had an amazing way to look at the world through the lens of definitely being a hero, but didn't think he was a hero. Just one of those people that just went through so much that I think just looked at every day as a gift. He's just one of the most positive people. And he taught me to live my life with the 3 Ps, both purpose, passion, and persistence, and that had me spend a lot of time thinking deeply about things I wanted to do, because he believed that if you can get a solid vision for you want to go, the most important thing is if you're passionate for it, then you will naturally be persistent about the endeavor, that you're not going to be likely to quit. And the more you have this purpose and passion, the more you tend to not see the obstacles. You just work your way around. So I told you a little bit about Cornell, and I don't think I really understood this purpose and passion thing until he came into our life. But to give you an idea how small he was, this is the doctor's wedding ring that went all the way up his arm. And so 23 weeks, he was born, he was a twin, 1 pound 9 ounces. And so, you know, the story goes that she was taking care of him. We were trying to get pregnant. Really fun time in my life. I was really trying hard, but nothing was happening. And, you know, we just were finally told we probably never have kids. And so, you know, that's a hard thing to hear. And meanwhile, she's taking care of Cornell. He starts breathing over his vent, and he's going to get moved to a home for profoundly retarded kids. And she just didn't think he should go there. And so she came home one night and was like, you know, I think all this is happening to us because I think we're supposed to bring Cornell home. And I think I said, no, I don't think that's what we're supposed to do, if I'm honest. But happy wife, happy life. We ended up doing that. This was the day we brought him home. He was about 15 months, and he weighed like 9 pounds. And what transpired was several surgeries where they had to completely reconstruct his trachea. And I'm not going to bore you with it, but we really almost lost him a couple times during that 7 weeks. They ended up having to retrach him and repeat that surgery, that 9-hour surgery, a year later. And then finally, about 3, he came to life. Caitlin came along the way. They were kind of our twins. And just what's amazing to me when I look at this transformation is I never saw him changing between the frames. He was just a kid with an insatiable appetite for life who never compared himself to his sisters. He just got up every day, accepted the difficulties, and put a smile on his face, and just got better. And so, you know, that's my message, my message to you is we're all like this, right? We can always find somebody who's it seems to be easier for. And who cares, right? It's your life, it's your gifts, it's your obstacles, and we get to choose whether we're going to get up and work at it or we're not. And so about 14, this is what I want to share with you, something really miraculous happened. Addison Kelly, my niece, was born, and we found out with a relatively new blood test at that time that she had cystic fibrosis. And Brian and Amy are great people. They, you know, he sells washers and dryers. She works at an orthopedic office. They do okay. They don't have tons of money. And they're finding out really quickly with the insurance stuff on them that the vests they would need would cost 20 grand and medicines and all this stuff. So it's piling up. So the family circles the wagons, and we're trying to figure out something we're going to do to help them. Cornell, being Cornell, was really interested in understanding about CF and asking some hard questions about how these kids die. And I didn't think about it at the time, but a lot of the respiratory depression he lived with is what happens to those kids. And so at dinner one night, he starts saying, well, Dad, you know, there's this thing on TV, and this kid shot baskets and made all this money, and I'm kind of ignoring him. And finally he goes, Dad, you need to listen to me. And I go, whoa, okay. There's this kid on TV and he shot baskets. I'm like, buddy, you suck at basketball. You can't do that. And he goes, I go, yeah, but what if I saw how many drives I could hit in a day? What if we do something with golf? So we called it Driving for a Cure. And he was a good little golfer. He loved to sit, you know, he was probably shooting in the high 40s at that time. He was 98 pounds soaking wet. And so he set up a grid at Cedar Point, where we were a member, and he had to hit a full drive 180 yards inside a grid for the ball to count. And we sent this out, and doctors and dentists, people I've been telling the story for a long time, they could be $1 a ball for one in the grid, 50 cents, or they could do a donation. And so the money just came piling in. So before even a ball was hit, there was already $9,800 there. So he steps up at about 7:30 in the morning. The first drive goes a little draw, 210, right down the center of the pike. And I turn to my wife and I go, this could get really interesting. So he starts getting into this groove, just smacking one after another. Figures out he's happier. You can't see it, but he's got his iPods in. And Caitlin's sitting down, putting balls down. He's just bam, bam, bam. He'd hit 1,020 balls in the grid by lunch. So he took a break, took a swim, put on his Tiger Woods outfit, and got back to it. And what was really cool is that our community starts talking about it and friends, and people start coming out, and then the news people come out. That's where I get emotional. Because he'd never really voiced why he was doing it. And so this cute little gal interviewing her just asked him, Cornell, why are you hitting all these golf balls? He looks right into the camera and he says, when I was a little boy, lots of people helped me through it. So now I am here for Addison. Brian and Amy are always going to be a good uncle and aunt, and I know this day is going to be hard for them. I just want to make today special for Addison and the other sick people with CF. And then he was back at it. So just shy of 7 o'clock that night, blistered, bloody, and exhausted, he'd hit 1,632 drives, over 200 yards. And at that time, we thought it was 59,000 he'd earned, but it ended up being 64 after everything came in one day. Now, what I want you to think about is if you would have gone back 14 years or 13 years, and you would have told us that Brian and Amy were going to have a kid with cystic fibrosis, and somebody was going to earn $64,000 and completely eliminate the stress and pain in their lives, it wouldn't have seemed possible, right? Would not have seemed possible. But yet he had a purpose, and a lot of his purpose was not just for his cousin, but it was what he went through. It was his passion from his own experience of his own life that led to this behavior that wasn't about golf. It wasn't about him. It was about something else. It's about making a difference. He knew exactly why he was put on that earth that day. And that's what we need. Like, we need this in our lives as dentists. We have to find something that burns. So there's a lot of stories about this kid. It's why I wrote the book. I will tell you that you are being blessed. He's bought you all the books, so whether you like it or not, you're going to get a copy of this, and you can read it. It's a good one. And what's cool, the rest of the story, Addie ended up being very blessed. In her condition, she has a specific gene of CF that when she was about 4, a new drug hit the market called Clydeco that basically has made her a carrier. So she's not symptomatic. He's completely convinced that his 64K was the thing that pushed that drug over the thing, which is totally cool. So that was 2010. She ended up becoming one of the people nationally on billboards and stuff for CF in 2010. And this year, she's on a full ride scholarship at Virginia Tech as a goalie. So that's crazy. I don't know what she's doing here, but she looks like she's having a lot of fun. That's freshman year. So what I want to continue to think about is, our goal in all this is to be content, to have this balance between work, love, worship, and play. I do think that one of the things that Dr. Dawson taught me is that if we can get really good control of our work environment, and I think that's one of the things digital workflows have done for me, is if you get more efficient, you can either work more and make more money, or you can be in the office a little bit less and have more time for the love and the worship and the play in your life. I felt a lot of my career, the balancing act was like work on one side and everything else on the other. And if I'm honest, as practicing, teaching, and seeing other, it's like this, and then I would take a break and it would switch to the other side, and then So I would encourage you, I saw a word that I really like. I thought this was going to be kind of retirement, but I was introduced to this word about a year ago, and I wish I'd have thought about it earlier, but I want you to think about this with your practice or things you like to do in your life, because if you can find things that bring these aspects of your life closer together, I like not to replace the word happiness with a word called eudaimonia. And eudaimonia eudaimonia is a word that is beyond happiness. It basically means, so you get it built here. While happiness is a common translation, eudaimonia encompasses a broader concept of well-being, encompassing not just pleasure, but also purpose, meaning, and living according to one's values. I want you to think about your practice and think about the procedures that you do that bring those things together. And for me, when I'm doing this digital high-end restorative dentistry, I'm there. I feel like I'm playing. I feel like I'm giving back. It's almost a spiritual experience for me. I want to do the rest of the years, I want to do the best dentistry of my life on people that care about it. I certainly want to mentor and support Caitlin in helping her vision. And another huge part of my vision now is making sure Dr. Dawson's legacy and the things he worried about when he was dying, which was that digital dentistry might kill his principles. That's why I'm doing what I'm doing. That's why I'm in front of you. I want to make sure these principles live in the digital world. It's why I still go all over the place and lecture. And it's also why we created this program, which we'll talk about here in a second. Make sure your vision goes beyond this. Make sure you've got stories to tell. You don't have to write a book, but make sure that you've got time to be with these people in a way. You know, why go digital? You know, why should you go digital? Well, I think it has to be about taking exceptional care of your patients, but I also want you to see it is a vehicle for you, once you get over the hump, to have more control over your lives, to be able to do better dentistry more efficiently and more profitability. And that's going to only translate to a better life. So with that, I'm about exhausted. I'm about 12:28. I told you I'd stop at 12:30. Again, thank you for being here, and I appreciate it. Thanks, buddy. Yeah.
Wow. Right. I mean, to keep an audience of endodontists and periodontists and prosthodontists and restorative dentists this engaged for this long was really unbelievable. I had about 10 people come up to me saying, "This is excellent. This is amazing." So thank you so much.
Welcome.
You've given us so much. I learned a lot. I had to come and go a little bit, but I learned a lot. That was amazing. Question. We may have some questions we may have some questions from the live stream. Nothing? Okay. Question. I'd love for you to tell us a little bit more about CCDD, the Cranham Culp Digital Dentistry. Tell me a little bit more about that.
Yeah, so we started this out in 2020 with a group of about 20 docs as a proof of concept, much like you did. And basically, the reason it got started was that when Drew and I were trying to learn this digital stuff, it was really a nightmare because the softwares are not very intuitive. And so we would go down and spend some time with Lee, and we'd come back and forget, and we'd just get lost. And so the program encompasses a couple things, but the main thing it does is it gives you about 40 hours of video training by workflow. So if you buy 3Shapes or you buy Exocad and you want to learn how to mount a model, you open this video, you watch the 20-minute video, and you do it along with me. And once you learn the buttonology of the software, it'll take you 3 or 4 times, you'll learn that workflow. If you go down that road, I have people that try to do like 40 hours in a weekend. Don't do that. Like, just learn a workflow, then learn how to make a splint, then how to do a surgical guide, and pretty soon you'll have your staff doing it. We also have 6 keynote speakers a year that are from kind of cosmetic restorative realm, and those are 3-hour lectures on Fridays. We've been doing that 5 years, so you have all access to all that. And then we do one hour coaching session a month live that's also recorded. So it's really just there to sort of to support you. Digital dentistry is different than analog because of the buttonology. Like you can go to an analog course on a weekend and be introduced to an articulator, and you can learn to use that articulator in the weekend and come back. It's just hard to do that with the digital world. So we also have a busy WhatsApp group where people are like-minded dentists are posting, and so it's just been a really fun community. But anyway, so it's a monthly thing. You can come and go with it. We've extended a 15% discount to members of this group, and so we'll make sure that you get all the links and stuff so you can look at it a little bit more carefully with an email on Monday, but that's it. Yeah.
Thank you so much. Just to echo that, this is an unbelievable platform, and by being part of the UniFi family, just get in touch with us. You're going to get a significant break with CCDD. Tell me a little bit about the software, the treatment planning software that you were talking about.
Yeah, so I know you're going to be around a little bit, right, Travis? So well, you talk about it too, because we did it sort of together. But what year was that? 2012?
That's probably about right. 2010.
Yeah, 2010, 2012. We started to have this idea of being able for doctors to have one place to put all their data. So we have a lot of information up out there of how we do our smile design and how we do our TMJ occlusal exams, come up with the diagnoses, and then there's checklists to go through to do your 2D, and now we're starting to put in the face ad, which I introduced you to there. So I think anything that you can do to help standardize your thinking as you're coming through a case is important, because we all have these blind spots, and if you don't use a systematic approach to analysis, we miss stuff. And when we miss stuff, we don't find out about it until the case is in. And depending on how bad of a miss, we either have to look at it for the rest of our life and hope they don't notice, or they notice and we have to fix it. So.
Thank you again. I really appreciate it. Listen, guys, this is what the essence of this UniFi business is all about. We're not just here to sell you business solutions. It's about getting a group of successful, cohesive people together, and for all of us to go to what I call U 2.0, the next level, whether it's through clinical lectures like this, or on November 13th, you're going to get emails. We have a non-clinical lecture on investments and reducing overhead and all of the stuff that is very important to us. I'll get that. With that, I just want to again thank you very much, and I want to introduce you to Jennifer and Nick if you haven't met them already. Both super smart MBAs, and they're here to help you with any questions, thoughts, concerns that you may have. Once again, thank you so much, Dr. Cranham.
Appreciate it.
You had a question?
Question?
For the severely worn condition and the digital mounting, how do you correlate that with the average one-way mounting method versus just going the patient back or establishing the original angle to where he was before the wound? You are going with the average.
So here's the thing. You mean compared to like doing a panographic tracing or something like that, or compared to what?
Hence you are mounting directly without the face bow.
Well, remember a face bow is also an average, and so the JPD article showed us that we're both about 10 millimeters off, in the scale. So what I'm saying is, if you find an incisal edge and you change vertical dimension, you have the ability to add or subtract to your occlusal plane, whether it's upper and lower, to create a very aesthetic look, whether it's Franklet plane or whatever you're going to use. But here's what I think about occlusal planes. And Dawson's chapter on occlusal planes, an occlusal plane is acceptable if it's aesthetic and it lets the anterior guidance do its job. In other words, if it allows for posterior disclusion and it looks good, it's a good occlusal plane. So I'm not really that worried trying to get it back to what they were before they wear, because quite frankly, there's no way to know that. There's no way to know how it compensated. Even a fully adjustable articulator won't do that. You still have to make some educated guesses where that is. But we definitely want to have something that's level. We want it sloping back a little bit. We can see that all on the virtual articulator. And the other thing to remember is, even if we're off a little bit, we're going to be a little bit off in the temporaries. And so we're always going to be refining and adjusting temporaries and then scanning the temporaries, and that's how we determine the permanent. So we should be extremely close. Yeah, it's a good question.
Of all the asks I've had of you, this is the most important one. My wife was up at 6:30 in the morning buying baguettes from Paris Baguette. If you don't eat before you leave, I'm going to be in huge trouble. So please,
grab a sandwich.
Grab a sandwich and stay with us and mingle. Thank you again for
Thanks,
coming.
guys.
Really
Appreciate
appreciate it. Thank you.
Drew, I couldn't look at you, dude.
Yeah.
It was tearing you up. I'm like,
The minute you started, I knew where you're going. I started cheering up. You can do it.
Listen, a couple of things. One, I was right to be nervous in February. You are amazing.